Dr. Radhika, over to you. Could you please start the Ioccon 2026?
Yes, sir. Am I audible?
Yeah, you are audible.
Okay, sir. Distinguished faculty, esteemed speakers, honors, guests, and dear delegates, good afternoon to everyone for joining us across the globe. It is both a privilege and profound honor to welcome you to the sixth edition of IOCCON 2026, the International Online Conference. Since its inception in 2021, ICON has evolved from a visionary digital initiative into a truly global academic congress. What began as a pioneering online gathering has now matured into a respected international platform that unites experts, researchers, clinicians, and students beyond geographical boundaries. Today, as we inaugurate ICON 2026, we celebrate not only our sixth edition, but also 5 remarkable years of uninterrupted academic engagement, innovation, and collaboration. This year, we are especially delighted to host distinguished speakers and participants from diverse regions, which includes United States, United Kingdom, Dubai, Italy, Turkey, Germany, Nepal, Sri Lanka, Ghana, Malaysia, Singapore, Australia, and Nigeria. Such representation embodies the very spirit of ICON, a Congress without borders, united by shared mission of advancing knowledge and improving global healthcare. Being a fully virtual Congress hosted on Zoom, ICON continues to demonstrate how technology can bridge continents, making high quality scientific exchange accessible to all of us. ICON 2026 remains steadfast with its core objectives, which are to provide a global platform for scientific and clinical dialogue, to encourage young researchers and students to present and publish their work, to foster interdisciplinary collaboration, to translate research into meaningful clinical impact. To our keynote speakers and invited faculty, thank you for enriching this Congress with your expertise. To our presenters, your dedication to research and academic excellence forms the backbone of this event. To our delegates and students, your enthusiasm and participation have made this international gathering possible for the sixth consecutive year. As we embark on ICON 2026, let us engage into thoughtful discussions, exchange innovative ideas, build lasting collaborations, and strengthen the network that extend far beyond this conference. With immense pride and gratitude, I warmly welcome you all to 6th edition of IOCCON 2026. Let us make this Congress yet another milestone in our academic journey. Thank you all and let the conference begin.
Dr. Radhika, due to some technical thing, Dr. Efsun Some, who is organizing secretary, is not in actually in a meeting. So we'll just wait for 2, 3 more minutes. If she not join, then please introduce Dr. Kariba Sappa and he will start with his presentation.
Okay, sir.
Okay. We are waiting for just 2 minutes to, give the opportunity to Dr. Epson Some to talk, inaugural talk as a organizing secretary.
Yes, sir.
Dr. Efson is joining in another 2 minutes, so she will give her inaugural talk and then we'll start for the day today.
Yes, sir.
Hello, everyone.
Welcome, Dr. Efson. I would
So
like
sorry
to
about
introduce.
so sorry about I'm waiting because of the surgery, urgent surgery. So sorry about it.
It's completely fine, doctor. Let me introduce you. So this is Dr. Efson Some. She's an associate professor in oral and maxillofacial surgery at Baskent University, Faculty of Dentistry, Turkey. Her clinical and academic work focus on oral oncology with particular expertise in radiation-induced oral toxicities, osteoradionecrosis, trismus, and multidisciplinary support care in head and neck cancer patients. Dr. Some has authored and co-authored numerous peer-reviewed publications and international consensus papers and actively collaborated with radiation oncology teams in translation and clinical research. She is widely involved in international academic network and educational activities in oral cancer care. She currently serves as organization secretary of IOCCON 2026, contributing to scientific and organizational leadership of conference. We welcome you, ma'am.
Thank you. You're welcome too. Distinguished colleagues, respected speakers, and dear participants, it's a great pleasure to honor to welcome you all to the International Cancer Congress. Oral cancer remains a major global health challenge. Despite advances in diagnosis and treatment, late presentation, treatment-related morbidity, and disabilities to in access to care continue to affect patient outcome worldwide. Addressing these challenges requires not only scientific progress but also strong multidisciplinary collaboration, continuous dialogue between clinicians, researchers, and policy stakeholders. The primary goal of Ioccon 2026 is to provide a platform where evidence based knowledge meets clinical practice and where perspectives from different disciplines can converge to improve patient centered care. Over the next few days, we will explore a broad spectrum of topics, including prevention and early diagnosis and advanced therapeutic strategies, rehabilitation, supportive care, and emerging technologies in oral oncology. Our scientific program brings together experts from diverse specialties and regions, reflecting the reality that oral cancer cannot be approached from a single discipline or a viewpoint. We believe that the diversity is one of the key strengths of this Congress and a vital driver of innovation and meaningful progress. Ioccon 2026 is not only a forum for sharing data and expertise, but also an opportunity to foster new collaborations, support early career researchers, and identify future directions for research and clinical practice. Constructive discussions and critical thinking we will central to the success of the meeting. I would like to sincerely thank of all members of scientific and organizing committees or our distinguished speakers and our partners for their dedication and contribution to making this Congress possible. I also extend my gratitude to all participants joining us from different parts of the world. I hope that the seasons ahead will be intellectually stimulating, clinically relevant, and inspiring, and that Ioccon 2026 will serve a meaningful step forward in our shared efforts to improve outcomes for patients with oral cancer. Thank you for being part of this Congress, and I wish you a productive and successful meeting. Thank you.
Dr. Radhika, could you unmute?
Thank you, ma'am, for your addressing the conference. Now, I would like to start with the first presentation by introducing the first speaker, who is Dr. Karibasappa. Dr. Karibasappa GN is the head of Department of Public Health Dentistry at DY Patil Dental School. He is an trained expert in tobacco de-addiction at the Tobacco Cessation Center and currently serves as Vice President at IAPHD Maharashtra chapter. He has authored 50 national and international publications with his primary research focus on tobacco and its policy implications. Dr. Karibasappa has also spearheaded impactful community initiatives including DATA program, which is drug, alcohol, and tobacco addiction, through which he successfully engaged 150,000 high school students to pledge say no to tobacco. His academic contributions, leadership roles, and dedication to preventive health makes him a respectable figure in the field of public health literacy. Sir, we would like to welcome you to Icon 2026, and we would like to hear your thoughtful words on the topic legal challenges in tobacco control.
Thank you, madam. Thank you for your brief instruction. Can you enable me? Am I audible?
Yes, sir.
Am I audible?
Yes, sir.
Yeah. So, thank you for your brief introduction, madam. As my topic has been given to discuss on the enforcement of COTPA and its legal implications in respect to the implementation. Before I start my topic, let me refresh you with this story of Birbal and milk. Or probably you might have heard about this. We all know that Akbar and Birbal stories many. I would like to respect to COTPA Act and its implementation problems, which we are all facing. So Akbar has a big kingdom, and he always wanted his people to be very honest, moral, and happy. However, he wanted to find out how much honest people are there in his kingdom, how much happy they are in this kingdom. And he asked his one of the trusted aide, Birbal, what is your opinion with respect to the people being honest? So when the emperor asked this, Birbal replied, Your Majesty, sometimes people are appear honest until they are tested. So then this made the Akbar to introspect what I should do to really test what exactly mean. So he announced one particular day, evening, that I request all my residents, people of my kingdom, to pour according to your will and wish, a milk in a designated area and designated pot. And expecting by tomorrow I will come and see. This was the instructions given, and it was told overnight you people do. And this message was spread across the people through various modes and means. And it reached every people in this kingdom. And as night fell, the D-Day came. As we see in this Kali Yuga, selfishness appears. So a person whispered himself, if I pour water instead of milk, no one will notice. Others anyway will bring milk. So like this, another person also thought, like this whole people in this kingdom thought that if I pour a water instead of milk, no one will notice. Everyone else, others will bring the milk. That was the thought process of every resident, every people in that kingdom. And on the D-Day, Akbar came and opened the vessel. He was very shocked that everybody has poured water. The moral of the story is what? Responsibility. Nobody was held responsible. Nobody had accountability. Everybody thought that it is not my work. Others will anyway do on behalf of me. Something like milk and water store. So this shows that everybody thought that I am not responsible or I will not put milk, nothing will happen. So everybody started thinking like this and ultimately ended up in the whole pot was filled with water. So it means that if you want something accountability, if you want some responsibility, rather than expecting from others, I feel it should start from within. As we proceed with relate why this story was given in jest. So with this, I would like to bring to your notice we are all aware about this tobacco problem and what it causes. Principally, all our oral cancer, precancerous lesions are attributed because of tobacco and tobacco-related products. We are the second largest consumers of tobacco next to China. Around 28% of people are suffering, are using some form of tobacco. Around 40% of people are exposed to second-hand smoke. 25% of people are exposed in public places. It sees that because of this tobacco menace, around 1.3 million Indians die every year, which is very alarming. As the regulatory aspects of tobacco control started, people started shifting from smoking to now we are in the shows that around 20 million adults are smokeless tobacco form. Why? The people think that they are not much uh, shocking or more serious compared to smoking. That is the problem. So to address this problem, Government of India passed a legislation in 2003, and it was refined as Cigarette and Other Tobacco Product Act, COTPA Act 2003. It categorically emphasized that I will be dealing in today's topic with respect to Section 4 and Section 7. Section 4 clearly tells that there is an absolute ban on smoking of tobacco in public places. Section 5 of COTPA Act says that there should be a ban on advertisement of tobacco and related products. Section 6 says that there should not be a sale of tobacco to minors, from minors as well as to minors. Section 6B tells that there should be a ban of tobacco and its products selling in and around 100 meters of any education institution to discourage the young people from catching the habit. And Section 7 says that there should be compulsory health warnings on the smoking products. Sorry, to be clear, realistic tobacco products. So because of these policies, what we have achieved? What is the current status? The primary responsibility of enforcing the COTPA Act, major implementers are the National Tobacco Control Program at state level, national level, and district levels, comprising of squads from the health department, from the police department, from the educational department, and other food and drug administrative department. The primary responsibility of these people are to issuing the fines and challenges who comes across or who have been having a complaint with respect to violation of Section 4 and 7. So what we have achieved with this act till now, we are able to successfully enforce this legally, the regulatory approach of controlling tobacco by way of displaying a compulsory, making mandatory the 85% of displaying tobacco warnings with respect to the smoking cigarettes. And around 2,000 tobacco association centers, TCC, are been established in and around medical colleges, dental colleges. Toll-free quit line has been started. M-cessation tactics, that is with respect to mobile services to help the people who want to seek some counseling with respect to overcoming the tobacco habit has been started. And absolute, there is a prohibition or a ban of the sale of electronic cigarettes. And we have started the tobacco-free youth campaigns in and around the India, across the states to create the awareness. Until now, there is a data and surveillance which is being collected, shows that around 81%, 81 lakh of tobacco users have helped to reduce the tobacco. Apart from these programs which are being carried out in and around by NTCP, there are some external agencies which are supporting Ministry of Health and Family Welfare under the aegis of International Union Against Tuberculosis and Lung Disease, that is Union, where they are customizing the national workshop on COTPA. Because of their effort, they are able to give that around 350 million people in India are being protected from second-hand smoke. So these are the tobacco problems which are there in India. Some acts which have been enlisted, which are being enforced, and some success is there. It's not that we are not found across some success, but there are some implementation issues And there are some bottlenecks which I would like to bring to your notices. My dear friends, what are the challenges which we are facing? We have till now discussed, we have understood there is some law, there is some enforcement, there is some measures taken across India. But what are the challenges which we are facing, which we would like to overcome? That's my today's topic. So we have some issues with respect to infrastructure, with respect to legal aspects, with respect to surveillance. That's what we are going to discuss. The primary reason which has been attributed for lack, or the key gap which I'd like to bring to your notice, is it's very easy to sell tobacco and alcohol in India by obtaining the licensing. It's very easy. But however, to give a proper analogy, another one is it's very difficult. Probably if I want to, sir, what you would like to tell is, if you want to sell a milk, you should go to every household and sell a milk or distribute the milk. It's not necessarily with respect to alcohol and tobacco. People go and buy, purchase. Similarly, with respect to establishing these centers, probably it is easy to establish these centers compared to milk. That's what my understanding. Apart from this, we are allowing the designated areas, some places, public places like airports, hotels, restaurants to smoke. Apart from this, we are allowing to sell the tobacco products at point of sale, as well as we are selling still now, even though it is loose cigarettes have been banned from selling. Maharashtra, the first state to ban the sale of loose cigarettes, still it is still available. And of course, we are not able to penalize the violators by the enforcement squad, as we discussed, not that strictly. These are some key gaps which I would like to bring to your notice. Apart from this, there are so many barriers. A study conducted by Ahuja in Daman is very clearly, categorically, I'd like to acknowledge and place it here. We can tell the barriers as related to law, related to community, related to implementer themselves. When it comes to law and its act, we don't have a very clear operational guidelines with respect to the implementation of these enforced laws with respect to CO2PA guidelines. I'd like to enlist and enlarge, elaborate in near future slides discussion. Apart from this, the responsibility or accountability, what I mentioned earlier, it's always been seen that it is only responsible of high rank officials. That is with respect to regulatory aspects. When it comes to community related issues, why this problem is still prevailing is poor awareness with respect to the existing laws among public, also among the enforcement people, also among enforcement squad. Apart from this, the vendors still involved in illegal sales. Culturally, we always accept tobacco as a not as a disease, tobacco habit as not as a disease, tobacco consuming as a only habit, which is culturally we are accepting this. These are some community related issues which we would like to address. Apart from this, implementer, there is no formal coordination among the multi-sectoral or intersectoral people between police department, health education department, food and drug, excise department, and higher officials. There is no proper coordination. Apart from this, fundamental another problem is very lack of infrastructure with respect to resources of manpower, money, and priorities. And of course, there is no supervised, centralized mechanism to observe what is going on with respect to our acts implementation. And most important is we inherently lack the motivation to discourage the tobacco habit among ourselves. The study was conducted in Daman to highlight the importance of these implementers' knowledge, attitude, and behavior towards the COTP Act. It's shockingly very poor and knowledge or awareness with respect to COTP Act Section 4 to 7 among police, who are the principal implementers with respect to this act. It was very poor. And smoking and chewing form of tobacco was consumed very, very high among the police only. Apart from this, another interesting finding about this, when you want to implement this law, apart from this, there's a lack of proper training for these officials with respect to tackling this problem. Administrative support is very less. And apart from all these things, they are already burdened with the existing criminal cases to solve or civilian cases to solve. Those are more prioritized than these tobacco. That is second, which is being considered. Apart from this, another study was conducted with respect to the awareness and compliance to anti-smoking law. And you would have seen that another one enforcement squad people are health officers, and they were really unaware what power they have with respect to penalizing the offenders or violators of this act. 92% of police admitted they found difficulty in implementing this law. They found these offenders penalizing was done only by police officers. Another study was conducted in Delhi, where the assessment was done with respect to the decentralization of this COTP Act with respect to the usage of the school authorities to implement this law, and it was found that there is no intention to among the school authorities or universities to implement this law. It is 2017 data. So what are the challenges we understood now? Why these challenges are existing? What is the problem which we are facing? Problem which we are facing is implementation guidelines are not very clear. For example, who has to do, who is responsible, and how it has to be done. So that accountability is missing. And another important is we have not having a lack of political will with respect to commitment towards tobacco control. Political will, until unless political will is there, we cannot overcome this tobacco menace which we are facing. So for that, resource limitations because of lack of resources with respect to financial support, with respect to the manpower allocation, with respect to infrastructure providing. If you want to ride a place where there is a complaint that there is a sale of illegal tobacco, who will do that? How it will be done? What is the financial involved? Those are all still not clear. Monitoring system is very weak. And most important, there is no licensing system to sell a tobacco and tobacco-related products in India. And apart from this, a study tells that corrupt enforcement officials, corruption themselves involved in this. And apart from this, tobacco industry interference, of course, the big lobby will be there from the tobacco industries with respect to, they will come and fund your political party. They might offer you gifts. They might bribe the people, delay the implementations with respect to policies by bribing the policy officials. Apart from this, lack of awareness about the policy itself, as we can see that there is no vigilance authority only with respect to tobacco and COTP Act influence. So who are the facilitators who can look after, whom we can look after and do this? We want a stronger implementation and enforcement mechanism by applying heavy fines, penalties, and if you come across deterrent level, they should be very penalized heavily so that they will be discouraged. I will be thinking second time, really I should indulge in this regulatory, legally. And earlier, this implementing the vendor licensing is most important. Apart from not only licensing, if you give a license, they should sell the tobacco and products only in the designated geographical place. Should be very clear. They cannot shift around because study is being conducted. Even though if you get a license, they might get a license and they can use that license in different places. Same license. No, that should not be, duplication should not occur. And still there is a violation, and if you see that license should not be used to open another shop, somewhere in another geographical location. So we should allow this tobacco selling to operate in a specific geographical location only. And it's not one time license we should provide. We should see that it should be renewed, revoked when there is a chance of violation of law. Apart from we have to minimize the tobacco industry influence with respect to the policymakers, its level, PMO office level, so that there is no undue influence by the tobacco industry people with respect to policy implementation for the officials. Apart from this, most important is creating awareness, health educations with respect to the banning the places where the smoking is there. Apart from this, what we can do is appointing a designated nodal officers nodal officer should be designated with some teeth in the policies so that insurance that CTOTP Act 47 is implemented strictly. And most important, there should be a coordination. There is no word I in the word team. There should be very good coordination with respect to government, between government departments, across the departments. And most important here, the police have a lot of informations, informers. We should use them to raid along with other departments. Involving, apart from this, whom we can use, we can involve the resident welfare association people, schools, general publics. Teacher should be given permission to sue them. It's there in the law, but it is not implemented. That's what I'm trying to emphasize. Teacher should be given, one teacher should be raised in education institution so that he or she will be given responsibility. If you come across any violators, inside the campus or in and around the 100 meters should be violated, should be penalized by teacher themselves. I'd like to bring your with respect to this COTPA violations, all years combined across states is available from NTCPA board state-wise. The one state is very good in implementing this, that is Kerala, Rajasthan, Tamil Nadu, Uttarakhand, followed by Karnataka. These are few states to name where they are implementing COTPA 7 compared to other places in a more meticulous way. And most important is this Kerala. Kerala is one state in country where they are the highest database which is available for us. In last 5 years, they are very strict in implementing these laws. Violators have been penalized. Challenge. So who can contribute to this? We understood till now the tobacco problem, the acts which is being conducted. Apart from this, all some studies to put the role of intersectoral. Who are the contributors? Of course, health department people, hospital research centers, NGOs can play a significant role by creating awareness, by public and political support. Police department, yes, a significant role can be played by a police department by creating awareness, by conducting investigations, providing security. Most important, security should be provided by the police department to the other departmental officials to make this, implementing this act a serious one. Education institutions can play a significant role. Higher education institutions can conduct research, studies with respect to the tobacco so that more evidence can be generated, more evidence can be supported to with respect to these acts. Food and Drug Administration people, they can conduct inspections, they can issue challenge, fines. So out of all these things, one thing is very clear. The key observations, what I would like to bring here is Section 4, yes, everybody is enforced, but Kerala is the one state which is implemented. Maximum booked cases are available from Kerala, followed by Rajasthan, Uttarakhand, Tamil Nadu, and Karnataka. Advertisement ban, very low. We don't have any much data with respect to the police records where they have been issuing challenge. Nationally, if you see the review conducted, 41% still non-compliance with respect to advertisement ban. When it comes to Section 6A and 6B, still around 50% of people are non-compliant with respect to the education institutions in and around selling of tobacco. Yeah, health warnings have been enforced, but compliance with respect to the graphics, 85% still exist. These are some key observations overall. So what are the solutions which I would like to, last part of my presentation, which is solutions, how we can solve these problems. First and foremost, we have to amend some existing laws. The definition of advertisement, which is there, only advertisement is banned. But now we have to include some surrogate measures which people use, public use, company use to influence the users. Camouflage advertisements are there. Digital influencers are there. OTT promotion is still going on. For them, the amendment should occur so that advertisement is broadly categorized. clear. Prohibition of sale of single loose cigarette. Maharashtra is state, first state to implement that, enforce that. Implementation still lacking. The designated smoking area, I personally feel that should be removed so that smoke free is enforced. Because there are some public opinions which I come across where public has opined, you people are giving smoking designated areas in airports, in malls, but it is not present in railway stations. It is not present in the STCs or schools or in bus transport facilities. So they think that this designated smoke area is a privilege which is only available for affluent section. We people who are traveling in buses or train are non-affluent, and why you people are not giving that type of places to smoke? That is the perception of public. Along with that, you are allowing the licensing to sell a tobacco by the vendor. Yes, agreed. But you are not allowing us to buy. You are allowing us to buy, but you are not allowing us to smoke there. It's a valid point. Yeah, they can buy, but where they should smoke? That is a question mark. Next is the amendment required is increased penalty, which I discussed. We have to now, of course, now Government of India has really increased that GST now February 1st, since February 1, fortunately, the tobacco related products have increased by up to 60-70%. It's a good move, right move to discourage the tobacco habit. Repeated offenders, graded penalties should be included. And they should be marked that repeated vendors, how the DL is revoked, driving license is revoked. Like that, any person who comes about the violation of these acts should be revoked or imprisoned. Another suggestion I would like to bring is dedicated tobacco control unit should be there. There is no dedicated tobacco enforcement cell. One responsible nodal officer should be given. He or she should be made accountable with respect to it when squads house. And vending license machines, yes, of course, I told. Apart from this, probably technology we can use where the GIC mapping, graphic, mobile apps has to be developed, distributed freely so that public can use that apps and give the complaints to the violators. Because many people might be wishing to do this, but the consequences might be harsh. So probably they might be afraid of reporting. So very confidentially they can report, and that confidentially should be maintained by the system. Judicial, whenever there is a litigation center, it takes a lot of lengthy time and the policy implementation becomes very difficult. So probably I feel that there should be a special designated magistrate only, so that he or she will be hearing these type of cases, litigations, and fast tracking. And any evidence, probably when that comes always based on evidence based. So any photographic evidence of violating, any cinematographic evidence of violating this, of course, with due consideration of nowadays AI generated and all, can be considered as a evidence to issue the challan as well as to imprison. Institutional accountability, yes, health department, mandatory, all schools should make a mandatory publication of this enforcing data. District level officer should come ask with respect to the schools, with respect to the authorities, with respect in and around what actions you people have taken. Like the teach should be given. Personally, this image tells that last few days back, probably I came across this. A grand woman, mother was resistant to allow this person who was violating this law. You can see in this image, he was trying to use this pedestrian designated place to move in this way. So she prevented that. Mother stopped that scooter rider from using that footpath. So there was recognition from this, from the police, traffic. She was honored. Like this probably helps the implementers to feel that their recognition or they are recognized. So apart from this, I would like to bring your notice about my few contribution in my tobacco field. So few publications with respect to the pictorial warnings awareness, with respect to oral cancer awareness, with respect to the attitude of the sale of loose cigarettes among vendors, apart from this, medical dental students awareness. And apart from cancer, not tobacco not only cause cancers, it is also involved in some dental caries problem. Like this, some few publications, scientific which is being conducted, others are in pipeline going on, and some patent with respect to the multidisciplinary approach, copyright which is being taken with respect to nicotine and vanadium dioxide using to assess the smoke in the public domain that is being copyrighted. So ultimately, I would like to conclude by saying that this tobacco product alone, selling, curbing cannot be done by one department or one section or one person. It requires a multi-sectoral, multi-dimensional approach where all are feel that they should be responsible to solve this problem. Because I feel cancer means cancel. So a coordinated, combined legislative effort, enforcement effort, technological support, public engagement is very much important, so that, as it is always said, that if you want to see a change in the world, should start within us. So with this, I would like to conclude the COTP Act is a very good, which has been enforced with few amendments, with for teeth giving, probably we can, a small change in our approach probably can solve this problem and make this world a tobacco-free India and reduce this tobacco-related disease and disorder which is going on and burdening the nation, burdening the person, burdening the society in a big way. I'd like to thank you, the organizing committee, to giving me opportunity with respect to the sharing my thoughts on this. I'd like to thank a special thank to Dr. Noorel for giving opportunity. Thank you one and all. Any questions? I am open for this. Thank you, madam. Thank you, sir.
Thank you so much, sir, for enlightening
Yeah.
us regarding such an alarming issue and also covering the legal aspects of tobacco. We are very fortunate to have you on this occasion, sir. If anybody has any queries, they can put in the chat box.
Hello, Karibasappa sir.
Yes. Good
It
evening,
was,
sir. How are you,
yeah,
sir?
yeah, I'm fine. It
Yeah.
was a very wonderful session and a knowledgeable one. What I wanted to highlight is why tobacco control. I mean, tobacco use should not be considered as a disease now. Like, in spite of giving so many instructions and all the these things, NRT products, and even the people are aware about, all are aware about the side effects and all those things. Still, the people are not leaving the habit. And actually, it is a topic to be considered, especially in the rural areas where we are working here. Their alternate patients are coming with the tobacco use, and nowadays even females are also there. Okay,
Yes,
so
sir.
when the person comes to this thing clinic, now we are working in a dental department. So if the patient, even in the medical section also, if he's coming with a habit of tobacco, it should be considered as one of the disease like tobacco use, and the diagnosis of that disease should be made as a tobacco use, and tobacco cessation therapy should be advised to the persons. That's what I feel. What's your opinion
De-
regarding the same?
Definitely, sir. Definitely. As I was mentioning earlier, one of the barrier which I related was three types of barriers. One is community-related barriers, one is regulatory barrier, one is implementary barrier. When
uh
it comes to this community-related barrier, we unfortunately think tobacco only cancer as a disease. The
yeah, that's
culturally
good.
we are accepting tobacco as a habit. That's the
Yes.
problem which we are having, and we should create awareness among public. In fact, I feel there is a bigger role of these parents nowadays or the female gender probably. Why means, without with due respect, female should avoid starting the avoiding. When we were earlier, people used to check whether he is a smoker or an alcohol consumer before giving a girl to the boys. Nowadays, it's not that, it's accepted. This habit is accepted. People, our parents were avoiding. So that means that much serious they were with respect to the tobacco and alcohol. Now it's not like that. It is accepted. Culturally, we are accepting this habit. The moment this has been sensitized, then probably this tobacco habit will be discouraged. That's my personal opinion. The moment these boys started smoking, girls should avoid getting married. They said, ek public toilet ka kata aisa kuch to. There is no public toilet, they are not marrying. Similarly, you are consuming tobacco, you consuming alcohol, girls should not marry. For that, first girls also should not drink and smoke. That's my take on this. And definitely, as you rightly pointed out, it's a tobacco is a disease habit. Tobacco habit is a disease, sir.
Yes, yes.
Unfortunately, we are not considering it as a disease.
Yeah,
That's my
that's what.
take on this,
Sir,
sir.
Yeah, yeah.
sir, excuse me, sir.
Yes, sir. Yes, madam.
Is she speaking?
I'm not able to hear, sir.
Yeah,
Probably
even
there is
that's.
some network
Yeah,
issue.
yeah, yeah, yeah. Now, there's one more thing I wanted to highlight, sir. While controlling the tobacco control and cessation, no, the awareness should be made to the patient's relative. Like
Yeah.
now, I don't know in what about the practices which you are having, the practice which are having in our areas. I am in touch with the rural population since many days. So they are under impression that once the habit has been started, it cannot be stopped. Like I'm trying to convince them in all the sense, like if everything can happen in this world, why not tobacco cessation, control and cessation can happen? Okay. So, what is my this thing suggestion? Like, if some they can implement this, it's very well. That for knowing that tobacco control and cessation can possible, that should be. I mean, it should be known to the person's relative, especially wife or mother, so that they'll convince their concerned person, and probably the persons will seek the advice for tobacco control and cessation. Your opinion?
We are not going counseling only the person who is into the habit. We of course we are taking the help of family members, because until as they support, that peer
Yeah.
support, family support is not there, he or she will be very difficult to overcome. Definitely, it's not only rural areas, definitely in urban areas also. So it takes a time, willingness. It things are that that's a perception. Unfortunately, that people think that we cannot overcome this. Once a habit, they think that H a bit. If you remove H a bit, if you remove a bit, still bit. That is the problem. That the perception that and the studies have shown that every tobacco consumer have once tried to overcome that habit, but unfortunately they have failed to and that they think it's not possible. It's not possible. I feel, sir, I want to quit. I want to overcome this. Give something to me. Give something to me. That's the alternative they expect from us. So we have our own ways of trying to overcome or help them, support them. But I feel a habit should be replaced with another habit, another good habit. That's
Sir, your
we
voice is
probably,
shaking.
Sir, I guess there is some issue with the
yeah, there
internet.
was a disconnect. Yeah, yeah.
Yeah, yeah.
It is restored, it seems. Yes. There was one madam probably wanted to highlight something. Hmm.
Anybody wants to raise a question? Please free to ask, sir. We will lend a few more minutes before we start with the next presentation.
Sir, good evening.
Yes, madam.
Sir, myself Dr. Deshpande.
Yes, madam.
Sir, I am a tobacco association specialist.
Yes,
Actually,
madam.
I'm pursuing my PhD and my thesis topic is on the same. That is awareness for pre-cancer, cancer regarding
Yes, sir.
tobacco related.
Yes, madam.
Sir, I visited many PSCs and many people in rural area.
Yes, madam.
But what I get there is feedback that people are not at all bothered about if we are saying I made one booklet for awareness, but I showed them everything, but they are not bothered about their own health also. And when I told them that they have to pay much today as they are paying 10 rupees for one pudi, but they have to pay much afterwards for treatment. What one lady said me, हमारा खर्चा सब सरकार उठा रही है.
Yeah, madam, exactly, you are right. That's what I told in my presentation. The lack of political will. That is
Yes, sir.
unfortunately lack of political will, madam. That is one point. And second, why they are not serious means health consequences. They are thinking, setting an example. I personally feel, sir, feel, madam, this setting an example we call as a doctors, they are seeing a doctors indulge in tobacco and alcohol, whether it is rural people or urban people. And we are not setting an example by only advising, practicing and preach. We all know, practice what you preach. But here, unfortunately, we only preach and we don't set an example. That might be one reason. Apart from this, as we discussed, COTP Act violations, discouraging. And most importantly, this tobacco person who is tobacco or alcohol consuming person should be concerned, should be viewed like how we used to view the HIV patient once upon a time. If we view the tobacco person consuming alcohol person something like a cornered untouchability, like I'm not telling in that way, don't take it wrong way, then they will think that I am smoking, so people are not coming near me or not appreciating me. Then probably they'll be discouraged to overcome their own habit. Because everybody who is buying this product, they're telling 85% covering what we tell. Yes, they know, they buy star and they keep next to their heart. That is the problem which we are
Yes,
facing.
yes.
So with setting an example, I feel for your question probably setting a good example and implementing very strictly the COTP Act, which is very good, and coordination effort of everybody, and most important is catching them young. Once the habit starts, it's very difficult to overcome. So sensitizing the students, sensitizing the very environment, parents should never, kids should never come to know that parents are smoking or parents are consuming alcohol. Parents smoking or consuming alcohol, definitely they will try. Definitely they will try.
Yes.
So you are not setting an example in your home, then what in the environment we can expect? So it should start from very much in our home only. That is very wrong. That is very bad. Not only with respect to health, with respect to other issues, financially, how it bleeds us, then definitely the prevalence will come down. The severity of this habit will come down. Now it has become a high now. And to indulge in the tobacco and other product habits, very difficult for them to counsel also nowadays.
Yes, sir. Very difficult.
Yeah.
Sir,
But
actually,
with continuous effort and with persistence, perseverance, definitely we should not lose the hope. And these type of conferences, organizations, like-minded people should join hand, everybody, and things will happen, madam. We should not lose the hope. Sorry, madam, you were telling something.
yes, sir. Yes, sir. Definitely we should. And next, uh, can you share your email and number? few things with
Yes,
you.
madam. Yes, madam. Yes, madam.
Or,
Definitely.
or is it from?
I think I have shared that in. No, I have shared earlier. I will try to share, madam. Now only that slide is there. I don't know how to share, go for that first slide. Dr.
Okay,
Yadika,
sir.
madam, can you help me to go to the first slide? First slide.
Uh, really sorry to interrupt, sir. Time
Yeah.
constraint is there. We have to
No,
start
no,
with the
only
next
first slide.
Okay,
presentation.
okay.
Only
I'll
first
take
slide
from
is
the
there.
organizing
Only
team.
first slide is there. That she wanted address. Probably she will take photo
Put
if you
put
don't
sir's
mind.
put sir's number on the this thing.
First
Na,
slide.
that is
No,
also
first
sufficient.
slide, it is everything is there, sir, in that. If you don't
Okay.
mind. First slide, very first slide
Sir, only you can share that. I don't have the access, sir.
is okay. Okay. I don't know. I tried that time earlier.
Sir, write down your number in chat box. That is sufficient.
1 second. Sir, 1 second, sir. Give me 1 second. Let's see. I have shared.
Okay, thank you very much, sir.
Thank you so much, sir.
Yes, madam. Yes.
So
Yes, sir.
let
Yes.
we shall start with the next presentation. So it's my
Yes, madam.
pleasure to introduce Dr. Ravinder Kumar, a distinguished public health professional with extensive expertise in tobacco control and national health programs. Dr. Kumar holds a BSc, MBBS, and MPH from PGI Chandigarh and further specialization with graduate certificate in global tobacco control from John Hopkins Bloomberg School of Public Health, Baltimore, USA in 2014. He currently serves as state Nodal Officer for Tobacco Control under the National Health Mission, Himachal Pradesh. Previously, Dr. Kumar has contributed significantly at both national and international levels as medical consultant with WHO and TEP Network India from 2014 to 2023, as technical officer at tobacco control at the Union East India Office, New Delhi, from 2012 to 2014. With over a decade of leadership in tobacco control and public health, Dr. Kumar brings a wealth of experience in policy implementation, program management, and global health advocacy. His work continues to impact communities by advancing strategies for tobacco cessation and strengthening public health systems. We are honored to have Dr. Ravinder Kumar with us today, and we look forward to his valuable insights. Sir, can we please start with your presentation?
Dr. Radhika, I think Dr. Ravinder has some urgent meeting. He is a, government, service person, and he's has some urgent meeting actually. So I requested Dr. Ramya to join, but she was saying that she would be joining post Dr. Ravinder. I'm requesting all my speakers
Yeah,
to please.
Dr. Lauren, I can start at 4:30.
Okay,
Another
no
five.
issue. ठीक है.
Yeah,
We'll wait for 3-4 minutes. No issue.
fine. Thank you
By,
so
by,
much.
by the time, we can ask anybody have any question, they can
Fine.
ask
Thank
question to
you.
Dr. Kariba Sabka. By
Thank
the
you.
time Dr. Ramya is joining.
Yeah. Just 5 more minutes. Thank you.
Karibasappa sir, are you there?
Yeah.
Yeah. Did you get any feedback from the persons who had worked for NRT and they have succeeded in quitting the tobacco habits? Hello. Was my question noticed?
I
Sir,
think
can you hear
so.
me?
There is a technical glitch. Yes, sir.
Sorry, can you hear me?
Yeah, I can hear.
Yes, sir. Sorry, sir.
What I wanted to know,
Yeah.
have you given any person like NRT treatment and you have succeeded in that, quitting the tobacco habit of that person? Is there any feedback of that person and what way it has further helped you to achieve the more success?
Yes, sir. I'm having data. I will personally share with you, sir.
Yeah. Okay, if
Definitely.
you are having, okay.
Yeah, I'm having.
And if at all you are using NRT products, right? What all major NRT products you are concentrating on and success you have got with?
Sir, basically, actually, so again, there is some conflict of interest with that. I will
Uh,
compile this data and
uh
I will definitely share with you. Personally, I will WhatsApp you.
Okay, okay, okay.
Definitely. I will do that, sir. I will do that needful. Because there is some, actually, no, we are doing this with respect to the help of one association.
Uh-huh.
One,
So,
I'm comparing with another company. I hope you
okay.
got my point.
Yeah, I
So,
got it. I got it. No, no, like if that is the thing, we also would like to work with that company for to have to implement the same thing in our area also, no? Like if you can help us in that way also, that will also work.
can you hear me?
Yeah, you are audible, Dr. Karibasappa.
So definitely, because it's Ayurvedic product and that company I had a tie-up. So there is a promising results which I have found. They don't want me to share till now. So once definitely I will and I know, as I know you already. So definitely I would like to collaborate and tell you the results, sir.
Results.
There is some
Okay.
promising results are there. Definitely,
Okay, okay,
I'll
okay. I
update
mean,
you.
that will be very much helpful to the
Yes, sir.
society.
Yeah,
That's
yeah,
what.
yeah, definitely, sir.
Yeah.
Because I didn't now tell, sir, because the publication issue is there. That is the
Okay.
reason. That
Okay,
is the
no
only
problem.
reason.
No problem.
Yeah. Yeah.
Do we have any more questions for Dr. Karibasappa? Please feel free to ask him. So can we start with the next presentation?
Yes, ma'am, you can start introducing. I'll be sharing it soon.
Yes. Um, it is my honor to introduce Dr. Ramya. Dr. Ramya has built an illustrious 17-year career in oral pathology and microbiology. She earned a gold medal in her postgraduate program in 2008 and was awarded the prestigious Inspire Scholarship in 2010 to pursue her PhD. Her research contributions are extensive and pioneering. She has facilitated the validation of biomarkers for oral squamous cell carcinoma and oral premalignant disorders. As co-investigator on the DST TIDE project, she helped develop a neuroelectro simulator for xerostomia, an innovation that received two national level awards for novelty. Her work also includes quantifying human papillomavirus 16 and 18 in oral pre-malignant lesions and oral cancer, and collaborating with the National Center for Nanoscience and Nanotechnology, University of Madras, on a nanoscale flexible hemostat funded by BIRAC New Delhi. Dr. Ramya's academic output is very remarkable, which includes over 300 publications, 4 textbooks, 20 national patents, and 1 international patent. She has held several key positions, including research coordinator of the Institutional Review Board, guest editor for SRM Journal of Dental Research, and nodal officer for the National Institutional Ranking Framework Committee in 2020. Currently, she serves as Associate Dean, Professor, and Head of Oral Biology at Savita Dental College and is also Director of Triumph Academy. She supervises 12 PhD students and has delivered over more than 150 invited lectures to date. Her dedication extends beyond academics. She is deeply committed to community well being, offering subsiding treatments and promoting preventive disease management. With her outstanding academic excellence, pioneering research, and passion for public health, Dr. Ramya continues to inspire students, colleagues, and wider scientific community. We are very fortunate to have you today, ma'am. Can you please start with your presentation?
Yeah, thank you. Thank you so much. And thank you so much, Nurul sir. It's been a very, I would say, most satisfying journey being there with MedSkill. I'm really grateful for considering me continuously. It matters a lot. And I'm really so honored that it is just not alone Oral Cancer Congress. I've also been considered for the Pain Congress, which Nurul sir conducts. And quickly, and thank you, Radhika ma'am, for that wonderful introduction. So today's topic on patterns of metastasis, which I thought is very important, and we rarely speak about how metastasis happens in oral squamous cell carcinoma. And this is very specifically in the institutional experience, which we've been experiencing in our institution. So a quick look and introduction about the basics of, excuse me. Yeah. Okay. So the basics of oral cancer, is my screen visible?
Yes, ma'am, it's visible.
Yeah, thank you so much. Yeah. Okay, so we know that oral cancer is a very significant global health issue, and that is why there is very many programs about it, and there is a lot of concerns about it. And oral cancers, it is on the rise. I've been talking about this for the past 5 years, and Ioccon has been happening for past 5 years. The sad thing is, every year, the numbers are increasing. Earlier, we used to sign out oral cancer cases per month basis. The numbers were lesser, but now the numbers are increasing. I was seeing the previous presenter, Karibasappa's presentation. There is another very big entity which is happening parallelly, that is the non-habit related cancers. I do understand that tobacco-related cancers are still very dangerous, but still there is a very significantly parallel numbers are happening in terms of non-habit related cancers, especially in female gender. So that was mainly because of metabolic reprogramming, and that was the topic which I had spoken in the last year of Ioccon. So this time I thought I would talk more about the metastasis aspect, because everyone of us should know how severe things are happening and what are we doing as by working on oral cancers, and we are doing a lot of research on oral cancers, but sadly everything is beyond our control. So we are actually, very frankly, we are helplessly watching, though we have very high very advanced infrastructure to treat cancers, but are we able to prevent them, or are we able to give them a better quality of life? It's a very big question. We do cancer surgeries very frequently, and we have very advanced setups, but it is very saddening to see the number of cases being exponentially high. So that is something I would mainly relate to the metabolic reprogramming that is happening. And again, very specifically about today's topic. So we know that metastasis is the main characteristic feature of malignancy, and because of its spread into distant organs, getting into the distant organ and reducing its functionality is the main damage which metastasis happens. And we know that it can spread through either lymphatic, or it can take a vascular or a hematogenous spread. And so more about the molecular basis is what we need to understand here. So what causes metastasis? It is because of the loss of the intercellular attachment. Once the cellular attachment, either to the adjacent cell in case of epithelium, or attachment to the matrix, it can happen either way. So if that attachment loss is happening, then there can be a transition. So either it is going to be a carcinoma or a sarcoma. So when the cell detaches itself from its environment, its cellular environment, either from the adjacent cell or the matrix, there happens a transition, there happens to be an anaplastic change, there happens to be a change, and that is when the cell undergoes a motility, a feature of motility, and then it starts migrating. And when this happens, there is a huge, complex, very intricate level of genetic damages which happen. And all of them have a very, very, very strong role in contributing to the distance of metastasis to the particular organ which it has to go, and about the local invasion also. So all these molecules are most important, and that is why I've put them here. So there are very, very basic molecules like by order, cadherins are most important. And then there are the metalloproteinases, which are very key players, I would say, in case of stromal derangement. And once the stromal derangement happens, metastasis happens faster. So all of these are very basic. And then comes the vascular endothelial growth factor. So this VEGF, or whether it is going to be the hypoxia inducible factor, all of them play a very deterministic role. So patterns of metastasis, how is this happening? We just saw what is metastasis and what are the molecular basis. Then comes the patterns. How is it spreading? Which direction is it spreading? Because only then the treatment aspect becomes manageable, and that has a very, very important role in predicting the prognosis. So that is why imaging the metastatic spread becomes very important. Treatment planning is heavily dependent on understanding the patterns of metastasis. So we know that the oral cancer, the common oral cancer, or 90% of oral cancers are squamous cell carcinomas. So here squamous cell carcinoma, we know that it takes a lymph node spread. So I'm mostly talking about it. And the lymph nodes, most of them involved are level 1 and level 3. And that depends on the subsite of the primary tumor. So there are many subsites in the oral cavity, and the spread depends on where it goes and which level it goes. So depth of invasion is very important histopathologically and to the surgeon as well, to the oral pathologist and to the surgeon as well. And the tumor thickness, all of them are very important deterministic indicators. Advanced tumors, of course, will also demonstrate extracapsular spread. We know that, and that will have a very big impact on the prognosis. Sometimes hematogenous spread also happen, and if it happens, it goes into deeper systems. So for the graduates or undergrads or postgrads, if you're there, so this is what we are talking about. Been talking about the level 1 to level 3 lymph nodes. So you can very clearly see that the first level is always level 1, but sometimes if it is in the posterior region, it goes to level 2, can be A or B, and then it comes down to level 3 lymph nodes. So how is it happening? So what you should understand is the first most important point here is metastatic behavior is not uniform across subsites, which means if it is going to be tongue, the pattern of metastasis is going to be different. If it is going to be buccal mucosa, the pattern is going to be different. So site specificity has a very big important role in determining the patterns. So lymphatic spread, we know that mostly there is a predictable pattern in which it spreads. Tongue cancers mostly go to level 2 and level 3. The moment you see this, you should know that tongue cancers have to be handled very, very carefully. A more aggressive treatment is required for tongue carcinomas, and specifically when there is evidence of midline extension. So this makes treatment planning even better. And then comes buccal mucosa tumors that again spreads to level 1 lymph nodes and are often unilateral in early stages. Sometimes when we see, it might be clinically very, very deceiving, clinically deceptive, but the level of lymph node involvement would be deep down. And what we find in recent times is non-habit related carcinomas or non-habit related cancers are more aggressive, more severe in behavior than habit related cancers. So that is again very sad to see those characters which are emerging, the patterns which are emerging. And again, here the floor of the mouth lesion is very riskier in terms of bilateral spread, and it definitely goes to crossing the midline lymphatic networks. Hard palate and maxillary gingival tumors are usually going to the retropharyngeal group, and because of its posterior presence. So this is everything about the specificity and how the pattern is happening. So this is like a bird's eye view of everything what this lecture is all about. So if it is going to be anterior tongue, it goes to level 1. If it is going to be lateral tongue, it goes to level 2. Floor of the mouth is level 1 and buccal mucosa is level 1B. Lower gingiva is level 1 and hard palate is level 2 and retromolar trigone level 2. So how are we going to, or what is our institutional experience? Most of the time, the site of the tumor is exactly in line with the international literature. But there are other factors which we have been observing, and that is what is I'm going to talk from now. So tumor size and nodal burden happens to, this is again a very important finding which we have been observing. So the moment a tumor size crosses anywhere above 3.5 centimeter, which is of course very huge in terms of oral cavity. If it is something beyond that, by then the patient would have at least initiated getting treatment. Very rarely we come across such bigger lesions, but the problem now is even for smaller lesions, we are witnessing deeper and higher levels of metastasis, or more farther levels of metastasis. That's what is very important. And this is another very interesting finding which we have been observing. Presence of comorbidities. I already kept on emphasizing on the non-habit related cancers, and I would attribute most of them to the metabolic derangement, and this has a very direct role. So comorbidities, if they are present, how do they affect the metastasis? So 60% of patients had at least one systemic comorbidity. Now this is becoming very common. And which comorbidities are more common? Diabetes, of course, being the diabetic capital of the world, we are in a very serious health concern. It is time that the government takes very serious action in bringing down diabetes first, because diabetes tends to lead into many other problems, and we have been observing that it is slowly having a very big impact on the cancer occurrence, oral cancer occurrence, its prognosis, its behavior, and many other features related to cancers. The moment when I diagnosing a case, when I'm just focusing the slide on in the microscope, not even asking about the history, I would just see the cellular spread, the arrangement, the architecture, the depth of invasion. Immediately it indicates, I just ask my PG student, just check the history, see if there is diabetes. And most of the times it is. So that kind of difference patterns are indicative the moment you see the cellular architecture of oral cancer cases who are having comorbidities of diseases like diabetes. And tobacco exposure, of course, that's a well-known problem. And the problem here is when there are multiple comorbidities. So, for example, if the patient has got a tobacco habit, if the patient is a diabetic as well, then what happens is when we send the patient for a positron emission tomography, a PET scan, there is more FDG uptake, and this is attributed to the chronic inflammatory state which the body is already present. So that is a problem. So when comorbidities are present, the body is already in a state of very chronic inflammatory derangement, and there is a chronic inflammatory state. What happens is when there is very high inflammatory hypermetabolism, the PET imaging also is becoming challenging, and sometimes it even mimics metastasis. So there are many false positives which happen with patients with comorbidities. So that is something which we have to be very, very alertful about. And we face multiple challenges like this, and these are something which has to be really handled in a state of war footing. It is high time that there are very, very important decisions related to government policies are made related to comorbidity prevention, chronic disease prevention, because it is leading to manifestation into very serious disease conditions. So this is my recent publications. In addition to the institutional experience which we face, we have a very huge patient volume reporting to us every day. And our numbers are very much higher, almost 2.5 times higher than the government institutions and government hospitals across the country. So in addition to the data which we have from our institution, we also had an opportunity through my student who was able to procure the data from North India, because we were very curious sitting here in South India. Just wanted to see how the patterns are there when we happen to get data from Delhi NCR region. And this was again a very big eye-opening. It was in most of the data which we had researched was very similar to the research data which we had been experiencing in our institution. So this is something which we have observed in the data which we collected from Delhi NCR region. So these were the observations. So we could see that tongue and buccal carcinomas were the highest from those regions, and most of them had very different metastatic kinetics. The tongue lesions exhibited a predilection to disseminate throughout the neck, and that is because of its bilateral spread. And additionally, the buccal tumors as well, though they're not that aggressive than like the tongue lesions, they also were tending to show dissemination. This could be because of I would attribute, because the number of tobacco users, from our experience when we travel to North India, the numbers are slightly more is what is my assumption. I might be wrong. So that could be maybe reflecting in the data which we have here. And the graphical representations here again showcase some interesting findings here. You can see that there is a cluster visualization of comorbidity types versus nodal burden. So you can see that cancer which did not have comorbidity, the nodal pattern was slightly lesser. It was not that aggressive. But in those cases where there were comorbidities, there were definitely patterns where they were seeing in multiple levels of lymph node metastasis. So that is something which all of us should watch here. And this is a very, very serious issue. And there is so much of preventive health policies which needs to be made. And this is also very important for surgeons for treatment planning. And it is also important to us pathologists, because every time when you see a case, when you get a case, ask for a thorough systemic history, and that would anyway be reflecting in the slide. But please do ask for comorbidities, and that will have so much of leads to tell in that particular slide. And there is a very big responsibility on the surgeon's shoulders as well. The moment you know that there are comorbidities, the treatment becomes slightly more aggressive. And once you know that the treatment has to be aggressive, follow-up becomes very, very important. So follow-up is something which has to be done every 6 months. The patient has to be very closely monitored, because what you need to understand is there is a chronic disease. The chronic disease leads to a chronic state of inflammation, systemic chronic inflammation throughout the body. And this chronic inflammation leads to very bad cellular architectural changes. And this, in the presence of other morbidities or in the presence of other habits, becomes more damaging. So all these are a very big vicious circle which happens, and it has to be very closely monitored. And this was recently published by us in Oral Oncology. And the take-home message for today is tumor size is very important biological indicator of metastatic potential, and it's just not a measurement. And lesions, as already mentioned, more than 3.5 centimeters definitely has a huge nodal burden. The moment you see clinically of whether if the size is bigger, then you must be aware that you may 90% or close to 99%, you may expect metastatic lesions in the lymph nodes. So those patients should be subjected to anyway, PET is mandatory. So when you do that, you should easily be able to convince a patient, and they have to have thorough imaging to see for any nodal burden. So that is very, very important. And additionally, there are other features which we see, which we closely monitor. So that is the depth of invasion, and angiogenic activation obviously is a very important feature of malignant transformation, and hypoxia driven EMTs. All these, if required and if the facilities are available by through proper VEGF grading and HIF grading, it can all add to derive better diagnostic algorithms, and then that can be given to the surgeon for handling it better. It is just not the surgeon alone. We know that these data, once we give a more elaborate report, makes a very big difference in planning for chemotherapy regimens as well. And it is again not chemotherapy regimens, it's about the radiotherapy regimens as well. So all of them makes a very big difference. And right now, the evidence related to the comorbidity and the linkage shows data which are not having that much of statistical significance, but I feel that there are huge data which mean we keep seeing every day in and day out the difference between cancers with comorbidities and cancers without comorbidities. Maybe the numbers which have been reported in literature are very less, or the numbers which are reported in literature, the difference is the study design. That is what is making the very big difference. So larger tumors definitely need very aggressive nodal assessment and lower threshold for elective neck dissection. And at this moment, I would really want to re-emphasize that as a pathologist and the surgeons have to be very, very alert in determining or predicting the patterns of metastasis when they look at the lesion clinically. And it is just not always about the pathologist and the surgeon. General dentists have to be super alert. And with our experience, what I'm going to re-emphasize again and again is it is just not alone. Don't keep waiting for tumor size which is more than 3.5 centimeters. Sometimes smaller, very, very smaller tumors, just very small ulceration, have shown level 2 lymph node involvements, and we have seen them in non-habit related cancers. So please be very alert, and please keep monitoring and practice preventive onco therapeutic management and diagnosis and screening. Screening is very important. And thank you again for patient listening, and I'm open for questions.
Thank you so much, ma'am. It was a wonderful session. Thank you for enlightening us with the recent concepts regarding oral squamous cell carcinoma. Anyone having question, please feel free to ask, ma'am. Ma'am, I myself want to ask a question.
Please go ahead.
I have seen the first presentation. It was regarding tobacco, and the next session was followed by you, OACC. So as you have highlighted, there has been alarming increase in the cases of non-habit related oral squamous cell carcinoma. So I personally feel somewhere people around me have been assuming that people without a habit are getting oral squamous cell carcinoma, whereas people with the habit are looking fine to them. So that might be a negative impact for the general population, I felt.
Yeah. See, that is something which people, especially smokers and alcoholics, people who watch them, and they keep telling that no, there is always a comment that those who smoke and drink don't get, and those who are teetotalers are more susceptible. So that kind of statements I keep hearing from this, I would say, more vulnerable population. Those are some statements which comes out from people who are less knowledgeable about the problem. That is what I would say. And this non-habit related group definitely will have a chronic disease, is what is my observation in the past 2 decades of my research experience.
Thank you, ma'am.
Thank you so much. Thank you so much for the opportunity.
Thank you so much, ma'am. So we will start with the next presentation. Is Dr. Gloria here?
Hi, I'm here.
Okay. Let me introduce ma'am. So Dr. Gloria Fifi Youngson is a dental public health resident with a clinical background in periodontology and a research focus on oral systematic health relationship. Her work explores the role of chronic oral inflammation as a modifiable driver of systematic disease, particularly in context of non-communicable diseases. She is committed to advancing medical dental integration through collaborative screening models, shared risk factor approaches, and primary healthcare strengthening. Her research emphasizes translating biological evidences into scalable public strategies in research limited settings. Through multidisciplinary approaches and implementation science, she aims to bridge clinical dentistry and broader health systems to improvise public health outcomes. Ma'am, we are very fortunate to have you today. Please start with your
Thank you.
presentation.
Thank you. Permission to share my screen?
Yes. Ma'am, you can share your
Okay.
screen.
Okay, thank you. Okay, just give me a second. I hope you can see my screen now.
Yes, ma'am.
Okay. Okay, so thank you very much once again to the organizers of this August event for bringing me on to share a few thoughts with you about how to cross over from biology to public health, and which is what I hope to be able to achieve with the little that I have to talk about this uh, evening, I guess, on your side. So it's pretty early morning on this side of Iowa, so I'm about 11 hours behind you into real time. So, yes, for decades, we know that dentistry and medicine have largely operated on parallel lines with the whole divide between the two systems or the two practices. And unfortunately, the biology of the diseases that we are seeing today are no respecter of these boundaries that we have set between dentistry and medicine. And as more evidence is mounting, linking oral inflammation to cancers and other non-communicable diseases, the question now is no longer whether a connection exists, but now how do we translate what we have found in terms of the evidence that is out there and to be able to translate this into actual or actionable prevention? And this is what I hope to explore today by figuring out how we can integrate the science that we have, especially with regards to how chronic periodontal inflammation is linked to this whole dysbiosis and cascade of events that leads to carcinogenesis, and how we at the population level, especially in terms of public health, can help to be able to identify these things early and be able to mitigate it and reduce the burden of oral cancers across LMICs. So will be by way of our introduction, our outline. We'll have a look at just a brief overview of the biological mechanism, which I believe that the big gurus in terms of the sciences have already dealt with in this conference, looking at just the epidemiologic evidence linking perio and oral cancers, and then into the main details or into the main meat where we look at the strategic frameworks that we can use for public health action at the various levels of prevention. Just have a case study of HPV and workforce training as a case study of how best we can use this tool to be able to prevent oral cancers at that level, and then look at some of the implementation challenges that we have, look at the strategies that we can use to overcome these barriers, look at how our future research priorities going forward should look like to be able to harness or consolidate what we have found in science to be able to bring it into measurable or scalable preventive actions. So we know the fact that oral cancers is a major global health problem, and the mortality, the numbers show it in terms of the fact that we have higher mortality in LMICs because of the late detection, persistent exposure to modifiable risk factors. So we tend to have a heavier burden of the oral cancer burden within low middle income countries, and periodontitis is simply one of the most prevalent common inflammatory conditions in the world right now. Globally, it's affecting a lot of people, and it's something that is modifiable, which is the interesting part. And then the key thing about it, I think the earlier presenter that just Dr. Ramia just mentioned how there's this chronic inflammatory state in these cancerous systems, and one of the major contributors is periodontal diseases, where it is found present. And she mentioned the other comorbidities, how she keeps finding diabetes in all these situations or in these severe cases of cancers that she's been meeting. And you realize the fact that most of these share risk pathways in terms of inflammatory pathways with periodontal diseases. Hence, the need for us to take a critical look at chronic periodontal inflammation. So there's that overlapping risk factors within all these inflammation and oral carcinogenesis. Then the public health opportunity. Now that we know that evidence is showing that there's that dysbiosis inflammation that can lead to self-filled cancerization, how best can we harness this low-hanging fruit? Periodontal diseases are common, they're detectable, they are modifiable, and it represents a very key and potential entry point for prevention. In terms of the global health burden of the intersection, so as of 2021, the global age standardized prevalence for periodontitis was standing about 12,500 per 100,000 population, which is quite a number. And oral cancer is about 17.7 per 100,000 population. And studies have shown the fact that there are higher disparities when it comes to the distribution of oral cancers in low and middle income countries. Higher mortality, about 82% of the global disease burden can be found in LMICs. There's lower 5-year survival rates following management because they are coming in late, we are detecting late, and by the time we finish whatever interventions that we can give them at the tertiary level of prevention, there isn't much hope for them. Then in terms of limited HPV vaccination coverage, whilst the world has moved higher, especially the high-income countries are fighting and gaining grounds with regards to HPV vaccination coverage, we still have a lot to do in terms of coverage for HPV vaccination across the low and middle-income countries. Then there's the shared high-risk populations as well, those that are taking in tobacco, the smokeless kind, the smoky kind, alcohol, environmental exposures, common conditions, comorbidities, as Dr. Ramia mentioned. So the global burden intersection actually does exist, and we are seeing the numbers showing this association. So just by way of biological mechanism, just an overview of why chronic periodontal inflammation can be contributing to this whole cascade. Usually once these pathogens find themselves into the subgingival communities, changes occur, oxidative stress, exuberant cytokine production as a result of the presence of these periopathogens. And it's usually the red complex group that are implicated in these mechanisms. So P. gingivalis, mostly F. nucleatum, and Treponema denticola have all been implicated in this whole cascade of chronic periodontal inflammation and the carcinogenic environment within the tissues. And the bacteria release certain components, certain products that end up causing other damage within the system. So we have most of the mechanisms are inflammation, as we've mentioned, in terms of the common pathways, inhibition of apoptosis. So P. gingivalis inhibits apoptotic pathways and is higher in patients with chronic periodontitis. Then P. gingivalis is also able to alter and dysregulate the key signaling pathways related to the epithelial mesenchymal transition, and this also affects the cycling, autophagy, and apoptosis rates that occur within that are supposed to occur with the tissues. Some of these bacteria also help in the production of carcinogenic metabolites. So you have periodontal bacteria producing substances like acetaldehyde, hydrogen sulfide, nitrosamines, which can actually directly damage DNA and promote mutagenesis within tissues or within cells. Then there's immune evasion and immunosuppression. Most of these bacteria have been able to develop virulence such that they can generate these myeloid-derived dendritic suppressor cells from monocytes and cytotoxic T lymphocytes, and then create this immunosuppressed environment around them. And once there's an immunosuppressed environment, what it does is that it favors tumor growth. So what's the epidemiologic evidence in terms of linking periodontitis and cancer as we have it now? So there's a significant association between periodontitis and oral squamous cell carcinoma risk. The one of the most comprehensive systematic reviews currently that had about 116 studies with 26 eligible quantitative synthesis showed the fact that there was a significant association between these two conditions. And a meta-analysis showed an adjusted odds ratio of about 2.32 for developing oral cancer in the presence of periodontitis. So that's like about 2 to 3-fold increased risk, even given in an unadjusted state. And most of these findings have been independent beyond tobacco presence. So they adjusted for tobacco presence in all its forms and still found a 2 to 3-fold increased risk with periodontitis in presence for oral cancers. Then approximately about 8.9% of oral cavity cancers are linked to poor oral hygiene. And one of the fundamental causatives in terms of periodontal inflammation is poor oral hygiene. So studies have shown the fact that there are increased odds with generalized gingival recession, clinical attachment loss, alveolar bone loss, missing teeth, with higher increased oral cancer risk. And these studies have also been backed by Mendelian randomization analysis that provide evidence for more causality in between periodontitis and cancer. So the numbers are showing, and the evidence or the science is also backing this cascade or this association. And I choose to call it the preventable continuum because periodontitis is something that can be prevented, or periodontal inflammation is something that can be mitigated, making it a low-hanging fruit that public health can jump on to be able to help slow down its contribution to oral cancer progression or development. So now to the main meat. With all these in mind, looking at the evidence, yes, the evidence is showing, the science is showing, we have a lot showing the fact that, yes, there's a need for us to start looking twice at periodontal inflammation in the presence of oral cancers and how best we can treat it. So for us as so I previously was a clinician before I chose to do public health to try and see how best we can bring the clinic to the population level. And usually once I see the science or the biology, then the next question is, how do we scale this, given all the plausibility that we are seeing, the causality and all those things that we are seeing? How can we bring it? How can it become beneficial to the population? How can we bring it such that it can help everyone in general, especially those who are at higher risk of getting oral cancers? And two key strategic frameworks that I can think of is the common risk factor approach and the integration into the existing non-communicable disease framework that we already have. So the Lancet oral, the WHO and the Lancet framework are advocating for a common risk factor approach in trying to address the role of oral health in oral cancers. And this framework recognizes that oral conditions share risk factors with cardiovascular diseases, diabetes, respiratory diseases, and cancers, including so some of the risk factors that have been mentioned with regards to the existing NCD framework include free sugar consumption, tobacco use, harmful alcohol consumption, and periodontal disease and oral cancer share these common upstream determinants. So there's that need to create opportunities for integrated prevention around these shared risk factors or common risk factors. So if we're looking right from policy in terms of comprehensive tobacco control, even including so yes, we already have a lot of legislature or policies concerning the smoking kind of tobacco, but now we are also seeing this new trend of high numbers associated with smokeless tobacco and nut products. So there needs to be that shift or increase in terms of control to affect these other brands or these other types of risk products that we have on the market. And then taxes, higher taxation on some of these risk factor products to be able to slow down its usage among the public domain. So the other key framework that we can fall on or we can utilize is to get or incorporate oral diseases as a sixth disease group within this 5x5 existing NCD framework. So the current NCD framework has a 5x5 where we have cardiovascular diseases, cancers, chronic respiratory diseases, diabetes, and mental and neurological conditions as the non-communicable disease, the five critical or five main non-communicable diseases. Out of these five, it is interesting to note that for four of them, periodontal diseases or periodontal conditions have similar risk factors with these ones, which is very interesting to note. So periodontitis or chronic periodontal inflammation has been associated with cardiovascular condition development, oral carcinogenesis, as we just discussed in terms of the biologic continuum, chronic respiratory diseases as well, and then diabetes due to the common pathways in terms of inflammation and the bidirectional relationship between periodontitis and diabetes. We see these two affecting each other a lot, and the science is well established concerning these associations. So it is interesting to note that there's a 5x5 that does not incorporate anything about oral health. Looking at the risk factors, we have unhealthy diet, tobacco use, harmful alcohol use, physical inactivity, and air pollution. So then on the other side of this, my diagram, I have like what an ideal 6x6 NCD framework would probably look like if we were to include oral diseases and sugary as the sixth disease for for the NCD framework, and then also look at sugary drinks and foods as a risk factor for some of these conditions as well, considering the fact that it kind of also ties in with unhealthy diet. So if you look at this, you're seeing the fact that a lot of these oral diseases are affecting about 3.5 billion. Oral diseases are affecting about 3.5 billion people globally. But then we do not have a place in the current non-communicable disease framework, which is very interesting and very sad to note. And if we are going to move forward in terms of being able to bridge and catch this menace of oral cancers at early prevention, then there's the need for us to come to that drawing table where we include oral diseases and oral risk factors into the conversation. So I feel like there are definitely various opportunities in terms of the levels of prevention that we can tackle this menace from, in terms of looking at the chronic periodontal inflammation and the oral carcinogenesis burden. Majority, like I mentioned earlier, for the lower middle income countries, most of our targets or most of our prevention seems to be at the tertiary level because our patients are coming in late and we are meeting them late in terms of detecting things late. And so usually by the time they come in, we are kind of almost already at the tertiary level of prevention. But I believe that this is the whole idea of us having this talk, is to be able to look at the lower tiers of prevention and how much we can buy into these levels of prevention to be able to actually catch things in the bud before they progress to the tertiary level. So the two key, sorry, the two key angles or levels that I want us to be looking at with the rest of our talk will be at the primary prevention level and the secondary prevention level. So at the primary prevention level, we are looking at how once again looking at one of the major risk factors or one of the major risk factors for oral cancers is tobacco and nuts products and they continue to be the leading causes in some jurisdictions like South and Southeast Asia, Western Pacific Islands. They are the main cause, and especially smokeless tobacco, which seems to be gaining grounds a lot. And tobacco control will continue to remain one of the cornerstones of oral cancer prevention. We can't talk about oral cancer prevention without talking about extensive tobacco control. So, one of the major things, yes, there are some places have tobacco laws, tobacco regulations, and all that. But usually, when it comes to the lower and middle income countries, the implementation challenges are very dire and very severe. So we have about 1.3 billion tobacco users spread across LMICs, but then there's significant implementation challenges of the laws or the enforcement of the existing policies. So there's that need, that active need for strengthening these existing policies, and also the need to also develop specific regulation frameworks for these smokeless components and areca nuts. So the current WHO regulations and policy documents tends to focus more on smoking tobacco, and there is less enforcement, or there's less policies or guidelines concerning the smokeless kind and the areca nut products. So there's the need, looking at how we are seeing that shift in terms of these smokeless ones and these nut products becoming leading causes in some jurisdictions within LMICs. It's very important that we include them into the framework for regulation to be able to nip them in the bud. Another low-hanging fruit in terms of primary prevention that we can actually deal with as oral health care workers is oral hygiene promotion and periodontal disease management. And good oral hygiene practice has been demonstrated to have protective effects against oral cancer. Studies show that having less than 5 missing teeth, annual dental visits, daily toothbrushing, no gum disease, and having regular food debris removal was associated with a protective benefit cancers. And periodontal health status may serve in this regard. Your periodontal health status may serve as like a surrogate for general health, kind of a window into your general health or your general well-being, because the factors that are contributing to your general health are also contributing to your periodontal health. So these similar shared risk factors, if we are putting up campaigns in process such that we are emphasizing that oral hygiene is actually a low-hanging fruit that can be used to reduce oral squamous cell carcinoma risk, then I believe that we'll be able to get somewhere with trying to incorporate good oral hygiene, which also has a protective effect from oral cancer for these patients or for our populations. So we need to have that comprehensive cancer prevention strategies that also incorporates oral hygiene promotion and periodontal disease management as well. So our public health campaigns should not longer be just about, there's oral cancer diseases, and then tell them just about the burden of the disease and why there's the need to be screening. But we can also give them some of these primary preventive elements that they can do at home from their oral hygiene and their periodontal disease management to be able to mitigate and catch these conditions at an early stages. So looking at the secondary prevention ones, one of the key ones is opportunistic screenings in dental and medical settings. We know that for LMIC, sometimes there's that dental shortage in terms of workforce and all those things. So medical settings might sometimes become the opportunistic screening centers for us to be able to pick up oral cancers. At the same time, dental settings can also be trained. Sometimes we tend to ignore looking out for oral cancers, even in dental settings, where probably we should know better. So it's very important that we take advantage of these opportunistic screening within these dental and medical settings, so that now regular dental care is no longer just about let's check your prophylaxis and all those things, but then let's also check, especially for those who are high risk patients, to be able to constantly check at the dental settings whether they are having any changes within their oral cavity, which can be quickly picked up. And if they have periodontal inflammation or chronic periodontal inflammation, we quickly control that state to be able to also give them that protective effect that it gives them as well. And the dental settings also becomes another advantageous place. For instance, one of the case study, as we'll look at it, looking at how children within a certain range. So you know how children tend to go to the dental clinics a lot. So that opportunity creates that room of contact, that constant contact between usually ages 9 to 12, thereabouts. And this is a very cute and a very good window, a good opportunity for us to be able to preach the HPV or the human papillomavirus screening and vaccination for this age group. So the dental setting at that point becomes a very good opportunistic place to screen for HPV, in addition to the oral conditions that we are looking out for, but screen for HPV and also recommend HPV vaccination for this critical age group as well, to be able to increase the vaccination rate for human papillomavirus, which also gets us that extra additive prevention against a lot of oral cancers who are usually HPV positive, which are mostly sometimes HPV positive. So the facilitation of these at the level of the clinic, medical and dental settings will facilitate early detection for both periodontal diseases and for oral potential pre-malignant disorders as well. And once we're able to catch them earlier, then we'll be able to provide prevention that will increase their survival chances. It will also help facilitate prompt referral, because then once we are catching it early and then we have integrated medical and dental systems looking at how, then now you can refer appropriately and then get these patients for their treatments to start early. So one major tool that we have right now at our disposal to be able to do primary prevention and secondary prevention, especially secondary prevention, is workforce innovation. There's a whole need for us to task shift to be able to enable us to be able to reach larger populations. Looking at the number of dentists to population ratios as we have in low and middle income countries, is simply not enough for us to be able to screen everyone. So there's a very high need for us to be able to multitask our workforce, for them to be innovative in terms of screening opportunities out there. So one of the major things that has been working in Asia currently is the use of community health workers, and their usage has shown a sensitivity of about 75 to 89% and specificity of about 91 to 97% in being able to detect oral cancers. And I believe that is a very huge mark as a public health practitioner. That's a good range for us to be able to trust this system. So there's the oral health curriculum competence based training program for community health workers. They tend to be the eyes and ears or the hands in places that we can't reach as dentists. And it's very good, important for us to train them for oral visual examinations so that they can reach these places. And I believe that is one of the most feasible and cost-effective screening strategies that we can pick up for the fight against oral cancers, especially in low-resourced settings. And the validated sensitivity and specificity lend credence to their ability to be able to help us in this fight against oral cancers. So one other place that we can do is the dental clinic team. We can also calibrate them and train them to be able to be ambassadors for oral cancers, for human papillomavirus infections. So the dental assistants can be roped in as part of their protocols for each patient, ask them, especially for those that are high risk patients for these oral cancers or this viral infection, they can add into we can train dental assistants to be able to incorporate these questions that will find out about their status, find out whether they've been screened before, provide screening services, and recommend vaccination at that level, especially within the dental settings, since they're going to come across a lot of these people who are at high risk for human papilloma virus for oral cancers. So there's that need for us to be able to train our dental clinic team. So yes, the fillings, the bread and butter dentistry is very important, but I believe that we can go a notch further by being able to calibrate our dental clinic team to be able to take up the charge on oral cancer conversations, human papilloma virus conversations with their patients, to be able to increase our prevention at primary levels and secondary levels. Then medical settings. Similarly, as we are training the dental clinic team, we can also do the same for medical settings. So physicians, physician assistants, nurses can also be that extension of the dental arm to be able to pick up, since they're already going to be screening for some common risk factor areas, especially for patients that are coming with cardiovascular conditions, diabetes, and other comorbidities. Once we are able to integrate oral diseases and oral risk factors into the NCD framework or the non-communicable disease framework, we can now train physicians, physician assistants, and nurses to be able to take that charge. So similar to what we are trying to push in terms of medical dental integration, where we are co-locating hygienists or where we are training physicians, nurses to be able to deliver fluoride vanish and all those things, is similarly as also calibrating them within these medical settings to be able to provide basic oral screening as part of it for us to be able to pick up some of these cancers at an early stage as well. And the key is to be able to screen high-risk persons as much as possible if we're able to innovate the workforce in this regard. Once we're able to broaden their scope for them to be able to reach out in these areas, then we'll be able to increase our reach and be able to cover masses and higher populations. And unfortunately, LMICs tend to have dense populations. So we've been able to spread our tentacles in terms of all these workforce being available would help us to be able to reach more people with secondary oral cancer screenings at a higher rate and be able to pick up or detect most of these at an earlier stages so that we can have better outcomes and better survival rates. And remember, your workforce, they're already there working for you. So us being able to teach them better to be able to meet this need or rise to this occasion is a feasible and sustainable tool that we can use. And it's one key public health we do to be able to reach the masses. So as the case study, I just did this graphic or infographic looking at integrating HPV vaccination in dental settings, like something like as an operational guide for dental providers. And this is something that we can scale to all other oral cancer conditions within the dental clinic settings. And similarly, we can also scale this to medical settings as well. So the whole idea is to be able to teach, like to set up, prepare, and train your staff. So what happens within these dental clinics is the fact that there's policy building. So you explain to your dental staff the scope of practice within the whole framework of HPV vaccination. What's even the essence? What are the current guidelines in your country concerning HPV screening and HPV vaccination? Once you bring your staff up to date, and then you create your standing orders as a clinic. So as a clinic or as a hospital, as a dental facility, what are standing orders concerning HPV screening and HPV vaccination and recommendations? Then usually, when there's no leader for anything or any project, it tends to fail. So one key and sure way to make sure that these things are able to be sustained and survive in our dental settings is to be able to designate a coordinator. So I term them the vaccine champion, or in this case, looking at the HPV infographics. So I call them the vaccine champion. So you have to designate a vaccine champion who will help coordinate the affairs regarding these screening and vaccination recommendations in the dental settings so that it doesn't become a chore or a burden for everyone. And usually when it becomes like that, people tend to let it go quickly. And by the time you realize we have stopped screening, we have stopped recommending, and we have stopped vaccinating people against HPV within the dental settings, then there's the need for us to constantly be training the dental team. So seminars, there are various seminars out there that talk about how to screen for oral cancers or other oral conditions, how to recommend HPV, how to vaccinate them. So some facilities can even choose whether they want to just recommend or they want to also go the extra mile to provide the vaccine in a safe manner within the dental settings. And then the fact sheets. So sometimes it's very important that we create these fact sheets for the dental staff such that they can refer to it easily within the dental settings. Because sometimes when they forget and they don't have that immediate know-how at their fingertips, then the likelihood that they will not do it becomes higher. So then once you have set up, you have prepared and trained your staff, then the next thing is what happens when the patient comes to the dental office for their visit. So you check their vaccine screening status, find out from them. Have they heard about HPV? Have they been told about the HPV vaccine, especially if they're in eligible ages for the vaccination? And why you tell them about how effective the HPV vaccine is. You now recommend it based, usually you see our patients respect us as providers. So if we are able to explain things to them, sometimes maybe they'll hear it out in the passing, in a newspaper article, in a newsletter, whatever it is, but it doesn't reach home or sink home as when your provider has taken their time to be able to explain the process to you. So when we're able to do this, we realize the fact that we're able to increase HPV vaccination uptake and increase also recommendations. So the provider recommends it, and if the patient agrees, you can either recommend and refer them, or you can also provide the HPV vaccine if you are comfortable doing it, or you are accredited based on your country's policies or your health sector's policies regarding vaccination for HPV vaccination. Then some of the key communication strategies that can be used in integration these oral screenings, HPV screenings, HPV vaccination, we need to normalize these discussions as part of the routine dental visits. So like I was mentioning, sometimes because of the bread and butter of dentistry, we tend to forget to ask these pertinent questions that can help us be able to look into a key window, as to whether there are any risk factors for oral cancers, whether there's the need for us to screen or look at these patients closer or even deeper. So then we need to normalize these oral cancer discussions, HPV discussions as part of routine dental visits. Then we need to address concerns and advice. Once the patient mentions the fact that they have some of these risk factors or these common shared risk profiles, there's the need to step in, address these concerns, and then advise. Don't just let the patients leave, oh, okay, and that's it. No, we need to address the concerns and then advise them appropriately so that they can be able to take the right step or the right directions, whether it means stopping certain habits or being able to get these vaccines to be able to protect them. Then also there's the it's high time we provide visual aids for these conditions as well in our waiting areas. Yes, mostly we like showing them the bread and butter videos and posters and all those things. But it's high time we also let them see the reality with regards to how these conditions look like and what can be done and what is available in terms of protection for them. Once we're able to do this, we'll be able to increase the number. Looking at just this framework, we can increase the number of people that are getting screened for HPV, getting recommended for HPV vaccination, and actually getting vaccinated for HPV as well. And that cascade also now transcends into us being able to prevent the rise of HPV-related cancers. And this similar input in terms of setting up, preparing, and training the staff is just a similar thing that we will do in terms of setting up, preparing, and training our staff for oral cancer screenings in the dental settings and in the medical settings as well. And some of the barriers will usually be the whole scope of practice, like every country has different guidelines, different dental regulatory protocols and all that. So you need to check with your place, find out the guidelines, what is acceptable and what is not acceptable. And then sometimes in certain places, primary prevention, secondary prevention like vaccination and all those things is like reimbursement. There are reimbursement options. So you need to find out whether there are reimbursement options for value for money for being able to incorporate these into your dental settings as a way of even encouraging dental practices to be able to take up the screening, the vaccination, and the talks about HPV and oral cancers. So the challenges are there. they run across in terms of the fight against oral cancers. So high tobacco use with weaker control programs, as I mentioned earlier. Most of our low middle income countries, we tend to have higher tobacco use, but with weaker control because implementation is just simply difficult when it comes to some of these countries. And it's high time that there's the need to push for tighter controls for us to be able to mitigate these challenges. Then the limited HPV vaccination, as I mentioned earlier, so is very low in a lot of LMICs, and there's the need to be able, if we are not able to bring it up, and right now that we are seeing a lot of HPV positive cancers showing up, then there's that important need for us to be able to push for this vaccination coverage, especially within those very high eligible ages who present at our dental facilities, who are found in our schools. So there could be school-based vaccination programs, there could be dental screening, dental system-based vaccination programs. There are so many settings that create avenues for us to be able to increase the HPV vaccination coverage, which will help protect us, especially against HPV positive related cancers. So currently, there's no systematic oral cancer screening in about 70% of LMICs. India is doing quite an amazing job in trying to screen as much as possible, and I believe it's a cue that other countries or other countries with such a higher burden of oral cancers should be taken from and learning from. And usually, because the other challenge is the fact that we are tending to have a higher percentage of the burdens also presenting at advanced stages. If we're able to work our way backwards and start from the primary prevention and secondary prevention, we'll be able to lower these numbers of cases that are coming in at advanced stages. And severely limited treatment access. So sometimes even though sometimes they might detect it, the financial burden that comes with cancer management and all those things becomes also a challenge. But one of the low-hanging fruits is periodontal management, as we've mentioned. It's common, it's preventable, it's modifiable. So good oral hygiene, at least one good thing that we can provide for high-risk patients and for individuals is good oral hygiene. So if we're able to give that to them, screen them early, we'll be able to mitigate some of the challenges associated with lack of access to good care when once they find these conditions or these conditions are present. So how can we overcome some of these barriers? I think I mentioned some already as I was talking about the limitations. So there's a need for strong community engagements. Usually, sometimes that positive word of mouth and community leader involvement, as practitioners or as people trying to champion oral cancer awareness, we need not to go in with a high-handed force or high-handed attitude. There's the need for us to be able to approach the community, especially get the leaders involved in any community, in any group. Getting leaders involved usually increases the ability of followers to also get on board. So we need that high-stake community engagement to be able to improve screening participation. If we're able to get their leaders involved and we find their leaders at our screening outreaches and all those things, you tend to realize the fact that the population itself or the members of the community will be easier to draw out to come for these screening programs. Then context-specific communication. So sometimes it's not just a matter of the science, but then their cultural beliefs that are backing some of their behaviors that are increasing their risk for oral cancers. So there's the need for us to be able to address cultural beliefs and reduce stigma around cancer diagnosis as much as possible, especially in settings where cancer is seen as a curse and all that. So in certain in certain African settings, you'd find the fact that cancer is seen as a curse from God, or you have done a crime, you've done something against God. All these cultural beliefs, all these myths, all these myths need to be addressed in these context-specific communication. So there's the need for us to be able to address it that way, to be able to improve cancer screening and detection amongst these within the context of these cultural beliefs and myths. Then patient navigation. So there's the need for us to be able to streamline our health services to be able to facilitate oral health, oral cancer screenings. Sometimes patients come and then from screening to care to finances to transport to lodging, it's a whole hula baloo for them, or it's a whole challenge. So they tend to give up easily. So once we are going to tackle this head on, then we need to be able to streamline our services to be able to enhance or facilitate the screening process for patients, coordinate care better. Once we detect a lesion, we need to be able to there's that integration with existing systems. So there has to be that coordinated care. Not that, oh, go here, then tomorrow this one says this. No, we need to have a coordinated care. That's eases the patient's anxiety even about that diagnosis and helps them to be able to settle and to be able to take their treatment and actually have better outcomes. Then there's also the need for us to be able to address financial issues, transport issues, lodging challenges. Sometimes at our levels as clinicians, we'll not be able to do that. But there's the need for us to be able to fight for health insurances to be able to cover some of these conditions and their management as much as possible to be able to offer these services at better rates for our patients or our clients and the population in general. Then integration with existing systems. That system of having oral, dental and medical on two parallel lines, looking at the science out there right now, there's a need for us to be able to intersect again. So we need to come to that crossroads again where we intersect. We need to find ways of embedding oral health into routine NCD screenings rather than creating the parallel programs that we currently have. So it's not for us to be able to add on to the parallel programs currently, but for us to integrate oral health into the existing NCD framework, which will be one of the major ways that we can overcome the barriers that we are currently facing as well. Then implementation research. Like I mentioned, the science is there, the biology is there, as we've talked about, all the plausibility is showing, but we need to be able to implement these into real world settings and to see how they can be sustained effectively. So we need to find ways of being able to increase our implementation research. Once we're able to get better results, or once we're able to see how actionable and how effective they are, then now we can push to actionable policies. And we can have the data and the science to be able to show to our governments, to our policymakers, for them to be able to buy into what we are saying about tighter tobacco controls, more regulation in terms of national health insurance schemes for patients, for the population, all these things. But we need to have done our implementation research for us to be able to have the figures and the numbers. I usually call it the evidence to be able to show our policymakers that this is in the right direction. Then now there's the advent of teledentistry. It's one of the key tools that we can have, especially for low resource settings. There's the need to buy into teledentistry to be able to reach our to maximize our reach. So sometimes, usually, especially, it works very well with community health workers. Once they're out there, there's no dentist there, all those things. Teledentistry can help them to be able to gather the information and transmit to the dentist in the bigger city, wherever, for them to be able to quickly assess these images, assess the information concerning these individuals, and to be able to quickly decide whether this patient needs to come in, whether we can monitor a lot of things. So teledentistry has come and is a good tool if we can find a very good way of harnessing it to be able to increase our oral cancer screenings, especially in underserved populations or in hard to reach areas. It's very important that we learn how to be able to use teledentistry to be, especially in conjunction with our workforce innovations, to be able to reach or bridge this gap. So in terms of future research priorities, we need more causality studies. So yes, the studies are showing the works that yes, there's associations, there's plausibility, all that. But we need more studies to be able to cement these findings, especially across the medical dental divide. Then there's the need for a lot of intervention trials in terms of microbiome targeted interventions as to explore whether modulating oral microbiota can reduce oral cancer risk. Now that we are finding out that these periodontal pathogens are having a role to play, there's the need for us to move towards intervention trials that target microbiomes to see how we can reduce cancer risk if we modulate these oral microbiota and their activity. And then, like I mentioned, implementation science, once we are doing these interventions or intervention trials, the outcomes can be implemented for us to see the sustainability in higher or larger population settings. So in conclusion, I would want to say the fact that periodontal inflammation is a modifiable carcinogenic driver, looking at all the evidence out there and the possibility that has been associated or that has been identified. And the strong association between these two conditions, that chronic periodontal inflammation and oral cancer, gives us an opportunity for combined screening of these conditions in our dental settings, in our medical settings, is one key way of integrating, driving that medical dental integration that we have realized that is very needed now, looking at how oral systemic associations are on the high, and adults with severe periodontitis have been shown to receive less oral cancer screening despite being at higher risk, as the science or the data is showing us. And this represents a very good opportunity for us to have integrated intervention. If you went to the medical setting, why it would be good for you to be able to get that screening. If you came to the dental setting, it will also be good for you to get these screenings. If you were out there in an underserved population where you didn't have access to a physician or to a dentist, we should be able to still be able to reach you with screening. That is secondary prevention methods or primary prevention, and that is through our workforce innovation models using our community healthcare workers and all that. So there's that low-hanging fruit and opportunity if we're able to integrate periodontal control into these public health systems. And I believe that it's one of the low-hanging fruits to be able to reduce the oral cancer burden. So the food for thought that I just wanted to leave you with as we're going back into our practices, as we are going back as clinicians and going back as dental directors, public health directors, all that, what level of evidence is the level of evidence that we currently have, is it enough? Or is there a need for more evidence to shift from just association as we tend to have it right now to policy action regarding these periodontal inflammations and their common shared risk factor profiles with oral cancers? Then how best can we operationalize medical dental integration for advantage in the fight against oral cancer? I've talked a lot about how we can drive the MDI route to be able to increase screenings. How best can you implement this within your facility, or how best can you start working on these MDI routes within your jurisdiction? And implementation, looking at one thing that we should also think about is what we see out there, maybe in high income countries. Does it automatically reflect in LMICs? Are the same strategies going to work for us as well, and vice versa? Or would there be a need for us to be able to tailor a lot of things to be able to suit our settings, to be able to get maximum impact from our fight against oral cancer? So on that note, I would want to say a big thank you, and I would like to acknowledge the organizers once again. Thank you for bringing me in to share a few thoughts with you about how best we can bring this MDI route to be able to challenge the burden of oral cancers, and to Us International as well for this association. So at this point, I would open up if there are any questions or there are any discussions or contributions. I'll be grateful for that. Thank you.
Thank you so much, ma'am, for such a wonderful session, for enlightening us the relationship between periodontitis and oral cancer. There has been few questions asked in the chat box, ma'am. Can you have a look?
Okay, so let me quickly get into the chat box and then see.
So they were asking, what is the best method to test viral associated oral cancer, saliva or tissue?
If I can get that question again, I didn't hear the question.
As we were talking about HPV-induced oral cancers, so there has been few cases. So the question was asked, what is the best method to detect virus or HPV-associated oral cancer, whether it will be a saliva or tissue?
So both have their advantages in terms of the whole screening process, or in terms of being able to detect the conditions. So you can't have a hard and fast rule about it. Ideally, if you could have both. Usually the pathologist would be able to tell us better as to which of these tissues they would prefer most. You know how sometimes you cut a tissue in the OR and then it'll tell you, no, we want an extra millimeter or we want an extra centimeter on it. But I believe that if you have access to any of these two, it's a good place to start from in terms of being able to screen or being able to detect these conditions. Yeah. I think another question says, how can we investigate correlation of PDL diseases and oral cancers? So there are lots of research already ongoing. There's been looking at databases. One of the very good places to start from is databases, and databases don't lie. That's the good thing about them. So usually if you have national surveys, it's a very good place to start from in terms of looking at the data. So where you have, so some surveys tend to collect data on periodontal markers. So in terms of whether they had periodontal treatments, whether they had periodontal management at any point in time. So if you have surveys or databases, it's a very good place to start looking at your research questions from. So in terms of once you get those research questions based on the data, and then you look at the what the trends are with regards to that particular population, then it makes it easier for you to now be able to look at how best you can target the two conditions based on the outcomes from your population. And one thing I want to say is the fact that no two populations are 100% the same. So that's how come it's very important for you to look at your survey, your database, or your population, the unique characteristics of your population. For instance, in in the US, aggressive periodontal diseases are not a thing. In the Europe, aggressive periodontal diseases are not a thing. So you know how the old classification, we used to have aggressive periodontitis, it has been scrapped out with the 2017 classification. And but when you're coming from a setting like mine, where in my clinic week, I used to see like almost 2 cases of aggressive periodontitis every week. That is something key for me to look at. I hope you get what I'm saying. So it's very important that we start our investigation right from our population, look at their characteristics, run the surveys and see the numbers, and then we can build on them. So in terms of HPV and PDL diseases, I guess it's something that we have to also start looking out for in terms of whether HPV positive associations has any links with periodontal diseases. That's probably something that has not come up much, and it's something that we should probably look at as well.
Ma'am,
And yes.
just a minute, I can interrupt. Like we're
Okay.
talking about the oral cancers and periodontitis. Like you suggest some criteria for it, like what kind of a periodontitis cases we should see,
Mhm.
and which biomarker especially we should go for in those cases for detecting oral cancer. Like,
Please come again.
should I talk again? Okay.
Yes, please.
The question of oral cancer and the periodontal disease relation, right? The which I had
Mm-hmm.
asked.
Mm-hmm.
Can you just a little bit specify like what kind of a periodontal, exactly what kind of a periodontal disease we should take in such research, and any particular biomarker of oral cancer should we look for in that disease?
Okay. So usually the for the as we talked about with the biology, one of the screening tools, once we are seeing the severe periodontal cases, especially those that have higher chronic inflammations, is very important for us to look at those conditions. So for usually, I mean, gingivitis and all those things, basic oral hygiene and these things can take care of them. But when we are seeing people with heavier burdens of periodontal disease or chronic periodontal inflammation, then we need to take critical checks for them. But then the key idea of also screening right from basic periodontal examination is the fact that we don't want to wait for them to come in with extensive or severe chronic periodontal forms before we start looking critically at them. So right from the word go, we should take it all serious for everyone. And then now we narrow down in terms of those who have severe periodontal inflammation. So looking at, if we are looking at in terms of the stages, we are looking more at stages 3, 4, as people that we should be worried about their level of chronic inflammation in their systems. Then some of the salivary or biomarkers. So we are looking at usually the same old age inflammatory bad boys. So the matrix metalloproteinases, the thermonecrosis factor alphas, CRP rises, all these are showing the fact that PGE2 is an indicator of tissue distraction. So these are all markers that we should be looking out for in terms of their rises. And I think the speaker earlier mentioned it, the fact that when they see some of these oral cancers, almost a majority of them to have some of these chronic inflammatory markers also on the rise, or chronic inflammatory conditions present, like diabetes and other comorbidities. So usually we see those common markers on the rise. So if you were to check saliva or GCF, you'd probably find some of these markers also elevated in oral cancer patients where they are associated with periodontal inflammation and all that, especially if the person has a heavy presence of periodontal inflammation.
Thank you.
You're welcome, Doctor.
Yeah, please give me your contact details further if I get something. Yeah, can I
Sure,
put in a chat box also
I will
the
do that.
email ID? Yeah.
Okay, I'll do that.
Thank you so much, ma'am, for your wonderful session.
Thank you very much for having me, and have a lovely day as well.
Okay, I wish you the same. We'll start with the next presentation. Do we have Dr. Ravindra Kumar in the meeting?
Yes, I have joined back. I have joined back.
Welcome, sir. I would
Thank
like to
you.
introduce about you. So it's my pleasure to introduce Dr. Ravindra Kumar, a distinguished public health professional with extensive expertise in tobacco control and national health programs. Dr. Kumar holds a BSc MBBS MPH from PGI Chandigarh and further specialization with graduate certificate in global tobacco control from John Hopkins Bloomberg School of Public Health, Baltimore, USA in 2014. He currently serves as State Nodal Officer for Tobacco Control under National Health Mission, Himachal Pradesh. Previously, Dr. Kumar have contributed significantly at both national and international levels as medical consultant with WHO and TEP Network India from 2014 to 2023, as technical officer as tobacco control at Union Southeast Asia Office, New Delhi from 2012 to 2014. With over a decade of leadership in tobacco control and public health, Dr. Kumar brings a wealth of experience in policy implementation, program management, and global health advocacy. His work continues to impact communities by advancing strategies for tobacco cessation and strengthening public health systems. We are honored to have Dr. Ravinder Kumar with us today, and so we look forward for his valuable insights. Can we start with the presentation, sir?
Thank you very much, Dr. Radhika, for introducing me to the August gathering. So I'm sharing my presentation. Right. So thank you very much, organizer, for providing me this opportunity. Let me give one update with all the delegates here, since many of you are oncologists. So, Government of India is going to launch human papilloma virus vaccination on 28th of February. So, I being the state immunization for state of Himachal Pradesh, so there was a meeting with the ministry, and under program setting, this HPV vaccination will be there. But again, previous speaker said that it should be there in the dental setting also. Maybe in coming years that can be part of the India's universal immunization program also. So we look forward that also. Right. So topic given to me is eliminate the major risk factor, that is tobacco. And I will be discussing about disease burden due to tobacco, brief on tobacco-related cancers, integrated approach for tobacco cessation, challenges and solutions, takeaways, and way forward. So I start with this picture, which actually explains itself. The cigarettes is well known as the only legal consumer product that kills half of its users when used as directed by the manufacturer. So I think this is one of the slide which every tobacco control activist they come across through. But there is one picture In 2012-13 onwards, we have very good advocacy group, which was led by Dr. Pankaj Chaturvedi from Tata Memorial Institutions, and they formed one Voice of Tobacco Victims, one pressure group, you can say, advocacy group. You can read from this picture. Thank you, Pehlwan Bidi. You made me what I am today. So means thereby, if I am committed to, I am loyal to one company or one type of tobacco products, that kills me prematurely. I think this picture explains everything. I start with this. Between 2005 and 2030, globally, 175 million people they will die because of tobacco-related disease if we don't do any intervention. We are doing some intervention, but there are definitely gaps in that. Tobacco suggestion in the Empower strategy, it is one of the last strategy which actually is given some serious concentration by the various government of the world. And India, it accounts for one-sixth of the world's tobacco-related deaths, as it is the second largest consumer globally. We are having right now we are going through third wave of GET survey, but the second wave of GET survey tells us that 267 million tobacco users are there in the country, out of which near 200 million are smokeless users, and about 100 million are the those who smoke actually. And we are also having fourth. We recently had fourth global youth tobacco survey, and we found that in the age group of 13 to 15, 8.5 students who are of age 13 to 15 year, they are using tobacco in some or the other form. And the age of initiation of tobacco products is as low as 9 years. So it's a serious challenge which our country is basically facing. And this again, Global Adult Tobacco Survey said that approximately 5,500 children they use on daily basis. So because tobacco companies they are doing this sort of advertisements and they need new recruit basically. So those who are addicted, they become their permanent customers. They die prematurely, and to run their business, they are focusing the children. Now, the tobacco landscape of India is quite different with the developed world. It is almost similar with the South Asian country. We are having different types of smoking form of tobacco. We are having seriously different type of smokeless form of tobacco. And you must be surprised in northeast region there is something which is known as tubule, where the tobacco products it is in the form of a liquid and we do the gargle. And this nicotine it is absorbed through the mucosal membrane and it also gives the same kick. So different kind of smokeless tobacco different and many of them are having regional variation also, and it's very difficult for the healthcare professionals to give the tailor-made tobacco suggestion services to them, and also very difficult to basically implement the rules also. And recently many international companies they are coming with heated tobacco products where just like the electronic cigarette, here tobacco leaves are there, it is heated with the battery, and there are vapors also. And then we had electronic cigarette as well. Very recently, now India is flooded with one another kind of a product which is known as oral nicotine pouch. If you can see me, so I am having this oral nicotine pouch with me. So it is having some pouches which are kept between the gums and the lips, and it is having the chemical nicotine. And every time new products are coming up in the Indian market because there are a large number of consumers here. I think I could see many of our Indian delegates in this conference, in this session right now. See, India, we are having gutka and khani, although they are banned, but they are sold in some different names. At the same time, our market is flooded with something known as pan masala, and all these companies very proudly they say we claim no nicotine, no tobacco, but this is not true. So in many states, like I belong to Himachal Pradesh, it's a state in another part of the country. In many states where food inspectors they took the sample and they tested in the laboratory and found that many of these pan masala brands they are having nicotine, just like the gutka and uh, gutka and khani. So they are not safe at all. And secondly, they are having areca nut, which itself is basically a cancer causing. So there is nothing safe. I mean, nothing like pan masala or gutka or khani it is safe. No smokeless chewing products are safe. And the disease burden, I think previous speaker also has said, globally about 80 lakh person per year. In India, 13.5 lakh, out of which 10 lakh smoking, 3.5 lakh smokeless tobacco. And it kills more than cumulative figure of TB, HIV, AIDS, and malaria combined in India. Tobacco-related cancer constitute about one third of all cancer in India, and this is as per the hospital-based cancer registry, which is maintained by under National Cancer Registry Program by ICMR. And if we see 48.7% of cancer in males and 60.5% of cancers in females, they are attributed to tobacco. Again, source is hospital-based cancer registry. And let us remind that this number is also underestimated figure because population-based case registry is also there, and many of cases are, they are underreported. And it's again very, very important thing that almost 90% of oral cancer burden is due to tobacco use. It is there in the public health and tobacco monograph published by ministry way back in 2014. So this is the one of the most common cause of oral cancer in India. You can see these pictures basically. You see the age of these all young people. They hardly are in their 30s. All of them are their 20 to 30 age group. And basically, this is the silent cry, the human cost of the tobacco. They must have started during their school days. They must have started by taking some pan masala, and then slowly, slowly, because this addiction, and they take maybe started with one pouch, and secondly, and finally, some of them are in earlier stages like leukoplegia, erythroplakia. Many of them have got tumor, and many of them have been, operated also. And there is another slide where these patients are actually there. And since you are an oncosurgeon, you are dental surgeon, so you must have seen such kind of. Because I am a tobacco control nodal officer, then from government side we have to support these patients in whatever capacity. So this is a very, very painful picture which we are actually facing. And these pictures, they are the pictorial health warning as per the Kotpa 2003, Section 7, where it says that, the cigarette pack, 85% of the area, frontal and back end, that has to be, that should bear this pictorial health warning. And these are all cases which are there in India. So it actually tells us that, the oral cancer, if we want to prevent the oral cancer, then tobacco we need to eliminate. So what I mean to say that it just don't kill, but it torture before it ends your life. And these are our heroes. I mean, so if you belong to, Indian setting, you must have seen these good picture. These are the brave hearts who for tobacco lost their lives, but not legacy. You must have seen in Indian movies where there is a smoking scene. So their message was there, but it is not there in last 2 years because they are no more. And they were our advocate. They have been operated by the oncosurgeon in India. Most of us know that, why people chew and why people smoke. There are non-physical reason. As a public health person, we have to walk here on this left side of what I'm saying. But here is where the physical role comes. Non-physical reasons, physical dependence on nicotine, relief from the withdrawal symptom. So they start one cigarette and another cigarette because of this craving issue. So that is the reason that people usually smoke. And earlier it starts as a lifestyle choice. It's a beginner, it's a symbolic act of rebellion. But soon that person knows that it's not a lifestyle choice. It makes a dependent state. And this nicotine, basically, if you see, so uh, addiction is a very complex process. And if we quit smoking, it leads to decrement in attention and cognition and impaired concentration, thinking, performance related with nicotine deprivation. They are the strong motivating factors to the smoke. Reason for quitting, it is addictive, it kills, and it is expensive also. Recently, tobacco products rates in India, especially cigarettes, longer cigarettes, has been increased as high as by 40%. And there are definitely benefits, as a oncosurgeon, as a dentist, whenever you see any person using tobacco, we can always say that, when you quit smoking, within 20 minutes, you will be, your blood pressure and heart rate will be returned to normal. So what happens after 12 hours? So there are standardized SOPs and these kind of facts and figure where we always say that, quit smoking, it's never late. And again, there is another aspect of understanding that how this quit smoking can help you. People of all age who have already told smoking related health problem, they still can benefit from the quitting smoking. So what's there in a cigarette? It's a full of chemicals, 7,000 chemicals, 200 known poisons basically, and these are the confirmed carcinogens as per the literature available. And in smokeless tobacco, here also the data says that more than 3,000 chemicals are there and 200 carcinogens are there. And basically, the the molecule which makes person addicted, it is nicotine. It's a drug, it's a stimulant, it's highly addictive, it changes our brain chemistry. It is found in tobacco products and now it is produced in the factories as well. So chemical nicotine is also there. And whenever we ignite the cigarette or we chew the tobacco products, the nicotine, it reaches our brain and then it spreads into the different parts of our brains. And there is a kind of what you call a reward pathway acts there, and it goes to the midbrain, and from there through the brain reward system, it primarily through the release of neurotransmitter dopamine in the limbic pathway, and then it includes the ventral tegmental area, nucleus accumbens, and prefrontal cortex. And nicotine, it reaches everywhere, and it gives the false sense of a pleasure, and it gives the sense of euphoria. And it is more addictive than cannabis, alcohol, cocaine, and heroin. There is a study published there, and that is the reason that if one person is, is addicted to nicotine, it's very, very difficult that person to quit. And this comes from the surgery textbook. This is a very classical case where it says that self-mutilation by smoking. This patient, it has all four limbs amputated for Berger type of arthritis. His cigarette holder was made out of a coat hanger by one of his friends on the ward. All the four limbs, they were amputated because of this Berger type of arthritis. I personally have seen one of the patients where he was operated third time, but he's not able to quit the smoking because addiction is very, very high. And do Indian wants to quit tobacco? We are having, I said that we are having gets to survey where we got the data that 55% smokers, they are planning or thinking to quitting. About 50% smokers, they are planning or thinking, smokeless tobacco users planning to thinking. And but unfortunately, only 48% smokers are counseled by health workers for smoking thing. And in last 1 year, 3.7 crore Indians, that is 38.5% smokers, they made a quit attempt. 33% smokeless user, they made a quit attempt. And almost 70 to 75% of tobacco users, they attempted to quit, tried without any assistance. So means thereby there is enough scope for quitting tobacco in India, considering its vast population and the very high rate of tobacco use. I think you must have gone through this again, a classical quote by Mark Twain. He's a famous American novelist, humorist. Quitting smoking is easy. I have done it hundreds of times. So, it's very, very difficult basically. So, since he's a humorist, so he could only say like this only. It's very, very difficult. But we always say here, it's very difficult because support is always needed. And for that matter, in India, in National Tobacco Control Program also, we are having integrated approach. So we have a behavioral support, we have a pharmacotherapy, and we have a professional involvement in this. And for smoking cessation, behavioral therapy, we are having brief intervention, which we call as a 5A, 5R, and then we have very brief advice, which we call as AAR. So what is this 5A? 5A, if I'm sitting in a community health center, or I'm sitting in a primary health center or a district hospital, so whosoever comes to my hospital. So I ask one question: Do you use tobacco? If he says no, sir, never, I have never used. So I say, very good. This is the best thing you could do to protect your health. But if he say, and I say, please never start this. Okay, this doesn't give you any benefit. But he says, sir, yes, I use. Then we always advise him to quit. And our message has to be very clear, personalized, and with facts also. Then we assess this person whether this person is going to quit in next 30 days. We assess that, I mean, we discuss that, and this is the basically this is the standardized module. If he is ready, then we assist him. We can give him counseling. We can support him with the pharmacotherapy. We can link that person with the national acute helpline, and then we can arrange his follow up. So for next 6 months, or say 1 year and 1.5 year. And after assessing, he said, "Yes, sir, I am ready." Then we assist him by a acronym known as START. We set a quick date for him. We ask him to tell your family, friends that you plan to quit. We anticipate and plan the challenges he will be having while quitting. And then we ask him to remove cigarettes and tobacco from your home, and then talk to your physician about getting the help. And there is another thing, after ask and advise, when I assess and I find that this person is not actually ready to quit, then we follow another leg which is known as a 5R. First is relevance. We actually ask this person, how is quitting most personally relevant to you, related to his health or his family or environment. Then risk, we ask that, if you keep on smoking, if you keep on using tobacco, so just tell me, I mean, what are the risks of smoking in this regard? And if we ask actually this person, if you quit smoking, what kinds of rewards you are having? So he will say, sir, better health. He can have better health, or he will save money. So he will save his family. And then we actually ask that, what are the different roadblocks? And as a counselor, we try to support in removing those roadblocks, and then repetition. It is found that many persons say they need to be given same advice time and again, and maybe in fourth or fifth time we counsel them by a cascade of healthcare worker, they are able to quit. So this 5R model works there. And this is the illustration of this, where ask, advise, assess. If he's ready to quit, then we arrange and then follow. If not ready to quit, this 5R comes in picture. He's not ready to quit, we end positively, because it will take time. To develop the habit, it took so many years. So quitting is basically difficulty, because this is the dependent stage. And another thing which recently Government of India National Tobacco Control Program, they came out with another strategy which is known as AAR. And it takes few seconds only, because you all are, I mean, clinicians are very, very busy. And then instead of going for whole this 5A and 5R, Government of India is suggesting that you just do three things: ask, advise, and refer. Ask and advise is same thing which is there in 5A, 5R, but for refer, they are saying there is a national acute helpline. You link that patient with the this national acute helpline. And secondly, there is telemanas 14416. And secondly, in many states like ours, we are having Nai Disha Kendra, basically drug addiction center, where we have a counselor and doctor trained in overall drug addiction center. We link these cases with such kind of addiction center, and there is a national acute helpline number. And it is said that, I know there are studies also, if a cascade of healthcare worker, they give this AAR advice to they follow this AAR strategy for a tobacco user, this is also giving the same results as compared to this 5A and 5R. And it is told that this brief advice, it has to be tailored to each group. So there is the old man, he is having dyspnea. So we can always say that, sir, you need to quit tobacco, because this your respiratory problem is because of this only, and she is having blood pressure. So all kind of these problems are associated with this. Is a pregnant lady, so we have to say that, madam, IUGR and this kind of problem, premature birth, low birth weight baby, this can happen because of the smoking. Our advice has to be tailor-made according to the our client basically. And there is something called turkey technique. It also works in India specifically, where after your advice and after seeing these kind of the picture I showed you in my previous slides, many persons, they say enough is enough, now we have to quit this, and they actually quit it without any kind of medicines, NRT or something like that. This also works, but people say the success of cold turkey is just 2 to 4%. Out of 100, 2 and 4 people, they stay quit after 6 months. So cold turkey, it works also, but the success rate is not that good. So success rate is basically complemented it is increased by pharmacotherapy. And why pharmacotherapy is needed? Because there are nicotine withdrawal symptoms like anxiety, irritability, restlessness, difficulty in concentrating, GI disturbance, craving, and drowsiness. And as a physician, you have to then prescribe the NRT. And Government of India, as in their programs, they have approved NRT nicotine gum. So 1 to 24 cigarettes and BD, 2 milligram gum up to 20 pieces per day for 12 weeks. And if the person is using more than 25 cigarettes or BD, 4 milligram. This 2 milligram, it is available over the counter, 20 and 4 milligram, it is on prescription only. If there is a tobacco user, then half the dose of the nicotine gum is there. So many states, they are giving this nicotine gum to the patients from government budget. So in my state this year, April onward, we have got approval from Government of India. We will provide this nicotine gum uh, from the national budget. So ministry is taking care of this thing. And second thing is nicotine patch. They are also approved. We started we started with 21 milligram patch for 24 hours for 4 weeks. Then we reduced this by 15 milligram for 2 weeks, and then 7 milligram. And there are another thing like nicotine inhaler, nicotine nasal spray. They are clinically approvable, but GUI have not approved them for supply under the government program. But these are also working. Bupropion, it is also very good drug for tobacco cessation. A good part is that it is started while the person is still using tobacco. We start with 150 milligram OT for 3 days. Then we increase its dose for 150 milligram BD for 7 to 12 weeks. And then we stop this. So this is also very, very effective drug. The Vernicillin is very good drug. It is used by many clinicians, oncosurgeon in India. The only problem is that it's very costly. So as of now, government is not supporting this, but many person who can afford this, so Vernicillin is very good drug as per the data available with the physician. And second line drugs are also there like clonidine, naltrexone, naltrexone, and antidepressants as well. The challenges and barrier in our country at all level, management, administration, healthcare worker, doctor, patients, their caregivers, unrest groups, women, youth, drug addicts, prisoner, drivers, etc. So frankly speaking, even in the program guidelines, this suggestion part, basically offering help in Empower O is the strategy devised by WHO. It came very last. So this suggestion, it was never as a top one of the top priority by the government. So budget was also not there. The healthcare workers, they are also not well trained in this. So at every level there were lots of challenges. And another barrier in our country is because it's a socio-cultural issue. There is a custom, and frankly speaking, I must admit that even healthcare workers, they themselves are tobacco user. Frankly speaking, there is one of the study in I think 2005 where it was proven that the NCD risk factor is 5 times higher among the healthcare workers as compared to general population, and so is the risk factor. So these kind of barriers are also there, and again, it is economic issue as well because, frankly speaking, about of probably 20 ministries in our country, 19 are basic. The mandate of 19 ministries are is increasing the revenue from the tobacco, and one ministry, that is health. So our mandate is basically protect the public health. So there is always a this kind of challenges and barriers in our country. And the solution, few of the solutions which I think we should have highest level of mass communications about harm of the tobacco. Access should be there to the drugs. It has to be affordable. It's very, very costly, by the way. The NRT in the private sector, full for one course, cost about 10,000 rupee. And it's very, very difficult. I mean, so for the public health programs also, and for the general public to afford, it's again very costly. Healthcare providers and their institution and councils, there has to be lots of training. There has to be the engagements and accountability. And whosoever do the good work, the counselor and the staff nurses and others in the field, they should be given recognition and rewards. And there has to be a proper system of evaluation and reporting. So this is one of my last slide. I think first speaker, I was there during the first speaker's presentation, and I think Dr. Abhay also probably said that why don't we consider this a disease? Yes, sir. The tobacco user, when he's addicted, it is a disease. Tobacco use is a disease, and tobacco use is a patient, and we must treat them promptly. I think there is no other solution. When a person is having oral cancer, then it's very very difficult. We have to treat this person early when they are actually addicted. So our takeaway is tobacco suggestion delivery. Physician oncologist can do it. Keep it simple. Counseling and pharmacotherapy together give high quit rates. Individually, probably not that much of, pharmacotherapy cannot work if the person is not ready to quit. And so is counseling. I can have highest motivation level, but since my brain is dependent, so it's very difficult without pharmacotherapy. So that means if both the things should be there. Use system approach, engage everyone in the health facility, sustain the delivery is essential. From ASHA worker in India to the onco surgeon in a tertiary care center, everybody should, motivate the person to quit tobacco. Managing data is critical. Besides showcasing, it helps to improve working because it's very, very important. Ji. Many person they are working in isolation, but it is not published in a peer-reviewed journal. So, what kind of strategy will work? It will not be replicable in other places. So, it should be there in program also. That data has to be there. Stay aware of challenges and barrier to solve them because at every place the challenges are different. India is a huge country, tobacco products are so many, and every district they have different kind of challenges. So my last point way forward is that it is for us healthcare provider to consider whether we wish to remain the part of the problem or we want to be part of its solutions. And I think the conference which you are having, and this is my first time that I'm running this conference, but but this is very good. I mean, you have this agenda there, and tobacco is the biggest cause for oral carcinoma. Then we should be part of this for lesser morbidity and mortality burden of most frequent and fatal tobacco detention in India. We start acting accordingly now, addressing their risk factors, tobacco first of all. 90% of oral carcinoma is related to tobacco use. So I think this is the high time we should start with the tobacco more aggressively. Tobacco dependence treatment is the way ahead. We are having a huge 27 crore Indians as per 2016, 17 GET survey says that we are a tobacco user. So this is the high time. Whosoever is tobacco user and they are having nicotine dependence, they have to be counseled, they should be treated, and the systematic and integrated approach should be adopted to treat them. So I stop here, and if there are any questions, uh, so I open the house and over to Dr. Radhika. Thank you.
Thank you so much, sir. It was really a wonderful presentation. Anybody having any queries, please feel free to ask to Dr. Ravinder, sir. So now
Yeah.
the participants are requesting email ID so that they can later on ask the questions. So can you please leave your email ID in the chat box?
Yes, I will be writing. Thank you.
Thank you so much, sir.
Yeah. Good evening, sir. This is Dr. Abhay Kulkarni again. Wonderful information. Like we are working in a different areas, but working on the same project probably. Uh, like in the initial first two slides, you said ki tobacco wash is been used, right? It was been like, I mean that gargles were used by some
Yes,
of
yes, yes.
them.
Tuber. It is a this product is known as tuber, sir, and it is there in 2, 3 states in Northeast. Mizoram, yes, Mizoram,
Uh,
and Nagaland, and what is there is another Meghalaya probably. So 3 states. In
okay.
Mizoram, it is used very frequently, sir. So they
Rohit.
take this, yeah, they take this tobacco leaf in a tub. They keep it there for say 15, 20 days, and after that it is packed in a bottle and it is sold in the shops also.
I see. Okay. Any commercial name for that? Like,
No, sir,
no,
nothing.
no.
It's a domestic product for them,
They
and
have prepared
they
itself.
yeah they do
Okay.
the gargle, and they
Okay.
say that all this nicotine it is observed. So
Okay. So
yeah,
what I wanted to know ki such kind of a thing, like when whatever practice I am implementing right now, Like if I ask them to quit immediately, the next day they are not able to quit. So instead of asking them, like they can curtail the use of tobacco by using this tobacco squish as such. So can it be used in our nicotine replacement therapy? Like initially, if you people are addicted to tobacco, especially the smokeless tobacco, so quit the habit. If they are using for 10 times, make it at least 5 times, and instead of that 2 times, you can use this. What you told, I have just forgotten again. The gargles, and
So
can it be used as a for tapering, like the way we taper the steroids, no, and then we quit it out, that way it can be used for a taper. Can we try that?
no, no, sir. I think that is again not recommended. The
uh,
reason being that you really don't know what is the concentration of nicotine in that liquid, sir. So this is
okay.
basically a domestic product, and I will say that we will be replacing one poison with the another poison. We really don't know what is the concentration in that.
Okay, okay,
But
probably the patient
yeah,
may get addicted to that part.
anything, sir. So we really don't know different kind of side effects can happen. I think the best drug which is there is the NRT, and you can actually monitor it. So that is with you. And this nicotine patch is also very good, sir. I
Yeah,
recently came across one patient. It's again costly, by the way. One
yeah,
patch
yeah.
cost as low as 100, sir. Every patch starts with 100 plus, sir. So these are costly basically, but at least they are as per medical protocols, sir. These local products, I think it will be very very risky, sir.
Okay, okay. Because these I am using with Nokia nicotine patches and this thing chewing gums, all those things. But again, the problem is that the this thing is very costly. Price of this, it is very costly. Okay, thank you.
It's very right.
Sir, I have a question. Can I ask?
Yes, ma'am. Sure.
Sir, nowadays we see the trend that non-habit related oral cancers are more prevalent. So can't the patient argue with us that patient who are not even having the habit history are anyhow getting oral cancer? So what's the point of me quitting?
What's the point of me quitting?
Quitting the habit like tobacco. People who are not even having tobacco, they are getting cancers. So even if I take, I don't take, doesn't matter. So why should I stop the habit? If they ask in certain way, how should we
No,
answer them?
no, you are very right. See, frankly speaking, if you see any consumer product in India or anywhere, everything, I mean, if you see that you will see protein, vitamins, minerals, something like that. You see these cigarette packets. So now in India, the contents of cigarette is there. So you will see carbon monoxide, you will see nicotine, and you will see every kind of poison enlisted there. So we can say, what I mean, what is the value addition while you are having this tobacco? And it's not only oral carcinoma. I personally know many, I mean, many doctors, so who have been who have been smoking for a longer time and now they are having stroke. You see many examples. I mean, who is working in tobacco, they have such example locally also. We can always say, tell us at least one good point about this. So it basically destroys your health. It's again a counseling thing which can always help. I give you the example of one of very good tobacco suggestion center maintained by one of our head of department of psychiatry in my medical college. He always say, whosoever comes to my place, starting, I mean, instead of telling him, you should quit tobacco because it harms and it has lots of health effects. He says, I asked him to, visit one room where he has serially pasted posters. He always asks them, you go and spend 10 minutes in that room. So all kind of lesion serially are there. And that person comes out of that room and then goes to that doctor, and that person says, "Sir, I have never thought that tobacco can cause this much. Now I want to quit tobacco. Just help me out." You see, that is also one of the things which is actually working. And I was very happy. So now, but I am as a program officer suggesting, right now I'm making one this kind of which MR people come with, this kind of a chart where all reasons, so which we will be giving to the Asha which work in the field. So at least she can basically tell the villagers that, tobacco can harm you. So this kind of folder we are actually now preparing our state, because this community-based counseling it will help. But your question is very right. Many people see. I think many people have said my grandfather he used to smoke since his childhood and he lived 100 years. And now you are saying tobacco kills half of his person prematurely. No, I don't believe in this. So I will tell this. I will respond this in another way. Tell me how many people they lived up to 100 years and they were smokers. There are 95% of the people who died prematurely because of this tobacco. In public health, this will work. One single kind of these outliers, they will not support their argument, madam.
Thank you, sir.
So I have written my email there. I mean, if that presentation is needed, so I can share with Dr. Nurul or Dr. Adhika to you, or whatever way. I mean, you suggest.
Okay, thank you so much, sir. So I would like to end the day one of IOCCON conference by stating the vote of thanks. It's my privilege to propose the vote of thanks of this remarkable conference by ending the day one. And I would like to convey my sincere thanks to all the esteemed speakers who has brought up their insights and knowledge by sharing and making this event more enchanting. And I deeply show my gratitude to the organizing committee, technical team, and volunteers who have worked tirelessly behind the scenes to make this conference a success. And finally, to all the participants for their active engagement and enthusiasm. Thank you all. Over to you.